Yes, Sahiti.
Yes. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Blossom Webinar in association with Maharashtra chapter of ISAR. So it's my privilege to introduce the President of MCOT Society, Dr. B. Kalpana ma'am. Ma'am is the Foxy Chairperson of Infertility Committee, Joint Academic Secretary of TAPISAR, Founder Secretary of Madurai Chapter of TAPISAR in 2020, Co-Chairperson of Infertility Committee TNFOG, past Vice President of MOGS, and also Organizing Secretary of MOGS Silver Jubilee Conference in 2018 and numerous conferences, member of Institutional Ethics and Principal Investigator in Clinical Trials, and also Course Director for Postdoctoral Fellowship in Endogynecology affiliated to MGR Medical University. And also, ma'am has received numerous awards. Best Doctor Award by MGR Medical University, Golden Excellence International Award by European Continental University, Medical Excellence Award in 2018 from Governor of Tamil Nadu, and also Best Medical Service Award from Madurai District Collector, and Best Committee TNFOG Award from Health Minister of Tamil Nadu 2022. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Actually, it is my honor to welcome you all for this wonderful webinar series, Blossom. As Hamid sir, in association with the Maharashtra chapter of ISAR, we have MSR President Dr. Amit Patki sir, who had joined as chief guest. And also we have Secretary General of MSR, Dr. Chaitanya Shimbekar, who has also agreed to join. So Dr. Amit Patki sir asked about the name Blossom. I've been telling about this terminology in each and every webinar. Blossom has been selected for this webinar on reproductive medicine because it represents the flowering part of a plant which will form a fruit. So symbolically, this name has been selected, and it is our honor to have Dr. Amit Patki sir as our chief guest, who is the past president of ISAR, now currently chairperson of Maharashtra chapter of ISAR. Thank you so much, sir, for accepting our invite. I know you were a little busy, had your talk in ICOG just now and completed and joined. Thank you so much for accepting our invitation. We also have our guest of honor, none other than Sampath Kumari ma'am, past Vice President of Foxy and also Dynamic Secretary General of Tamil Nadu Federation of Obstetrics and Gynecology, who has been running across India to reach her goal and wishing her best of luck for her future endeavors. And also we have very interesting topics which had been selected for this webinar. We have Dr. Chaitanya Shimbekar, who had gracefully accepted our invitation and associated MSR with Blossom. And he is the Secretary General of MSR and also a dynamic member of Foxy Infertility Committee. And he has been doing lots of work, and he is going to moderate a panel discussion on add-ons in IVF. Let it be in the investigation, let it be in the clinical part, let it be in the lab part. Let us know about the literature evidence and add on the thing in our clinical practice. We also have Dr. Kedar Ganla, who had accepted to be the expert in this panel, who is none other than past Secretary General of ISAR. It is our pleasure to have you here. And we also have expert panelist, Dr. Aditi Trivedi, Dr. Amog Chimoti, and Dr. Cheetal Dr. Upma Jaiswal, Dr. Anjana Jeevan, Dr. Shalini Dwivedi, who are going to share their knowledge, experience in this panel. And it is our pleasure to have Dr. Varsha Roy, who is going to moderate a panel on optimizing outcome in PGT. We need to know before going for PGT the success associated with it, limitations, and also skills needed for PGT. So we have experts in this panel, Dr. Priya Kannan from our own city, Dr. Deepak, Dr. Sujala, Dr. Suvachala, Dr. Ram Prakash, Dr. Meeta, Dr. Charulata. So with all these experts, I think with wonderful topics, this is going to be an academic feast for our delegates. So once again, thank you for joining and making this webinar a grand success.
Thank you, ma'am. Now I request Dr. Shanta Devi, ma'am, to introduce Dr. Sampath
1
Kumar.
minute, we will go for lamp lighting, Sahiti.
I request Dr. Kalpana, ma'am, to introduce our chief guest today, Dr. Amit Patki, sir.
So it is my honor and pleasure to invite Dr. Amit Patki, who doesn't need any introduction because he had been very dynamic over the past 2 years doing various webinars, master classes, and also conference. He is the medical director, Fertility Associates, Mumbai. He is also the country representative of Aspire 21 to 23, governing council member of ISAR 12 to 21, immediate past president of ISAR, now currently president of MSR. He was into MOGS also, President MOGS 2014 to 15, Chair West Zone RCOG 15 to 2020, and he has published 35 publications in reputed journals, 50 chapters, and edited 3 books and 2 international presentations in infertility and stem cell. It is our honor to have you here, sir. Your words of wisdom and blessings for this webinar.
A very good evening, and thank you very much, Dr. Kalpana, for giving me an opportunity to be part of this very famous and looked upon the Blossom series. I'm so glad that you have requested Maharashtra chapter of ISAR, and I'm thankful for Dr. Chaitanya Shembarkar for coordinating with this Blossom series. And I look forward to hearing 2 very, very trending topics, add-ons, and also on PGT. And I can see that the moderators and the panelists are well reputed. So I'm sure there are going to be a lot of take-home messages and some things that we can all improve our practices. I wish to congratulate Dr. Sampath Kumari and wish her the very best on her future endeavors in Foxy, and I think she's very, very well deserved and well reputed person to lead the organizations. So thank you very much, Dr. Kalpana, and to Chaitanya for bringing MSR and Blossom together. And I look forward to 2 very interesting, interactive panel discussions. Thank you so much.
Thank you, Dr. Amit Patki, sir. Thank you.
Thank you, sir. Thank you for your presence. Now I invite Dr. Shanta Devi ma'am, who is a secretary in MCOT, a former professor of Madurai Medical College, Madurai. She finished her MBBS from Tirunelveli and did a DGO in Kilpak Medical College and MD from Madurai Medical College. She was an undergraduate and postgraduate teacher in Madurai Medical College and Teni College for 20 years. She was the past president of Teni OG Society. She was organizing secretary for many live workshop at Teni Ultrasound 2018, Cesarean 2018, Endoscopy 2017, Infertility and IUI 2016, Colposcopy 2015. Presented many papers in national and international conferences and received Best Paper Award in Dakshin 2011 at Kanyakumari. She has a special interest in infertility, endoscopy, ultrasound, and high risk pregnancy. I welcome Dr. Shanta Devi ma'am and I request her to introduce Dr. Sambat Kumari ma'am.
Good evening, everyone. It's again my privilege and honor to invite our distinguished guest of honor, Sampath Kumari Madam, to grace this Blossom webinar with her input. She's well known to everyone. She's traveling all over our country, and she is past Vice President Foxy, and she is the founder secretary of TNFOG, the Senate member of Tamil Nadu MGR University. She is a national corresponding editor, Jogi, and she is the retired professor of Madras Medical College. She has received many awards, IMA National President Award, IMA TNSB Award, and I welcome you, Madam. She is very busy, every one of us know. She is contesting for the post of prestigious post of Foxy President election to 2026. I wish you for a grand success, Madam. Whatever post you hold, that is, I know as Vice Chairperson, Adolescent Committee, Vice President Foxy. So you have done a wonderful work, and I know how hard you work, and so the same we expect you as President, Madam. Wish you all success. And now I invite you for this to give your valuable input, Madam.
Thank you, Dr. Shanta, for the nice words. And thanks to Kalpana for the inviting me for this wonderful program. That is the Blossom with Maharashtra chapter of ISAR. And thanks to Dr. Kalpana and Dr. Shanta Devi. And I am really happy to be there with Dr. Amit Patki sir as the chief guest and me as the guest of honor. And you have the wonderful talks. One is on add-on in IVF, which is by Dr. Chaitanya. He will be discussing about, as Kalpana told, the laboratory techniques, medical procedures, and the pharmaceutical supplements. I think this add-on will change from case to case with the previous failure of the failed cycles. And you have that expert by Dr. Kedar and the wonderful panelist, Dr. Aditi, Dr. Natachandra, Dr. Sheetal, Dr. Upma Jaiswal, Dr. Anjula, and Dr. Shalini. And you have the second topic of optimizing outcomes in PGT. I think this pre-implantation genetic testing is always the multi-stage approach, and it is targeted on ovarian stimulations and embryology with the lab protocols of genetic cycles and endometrial preparations personalized. We have Dr. Varsha for this topic and the wonderful panelists with good interactions, Dr. Priya Kannan, Dr. Deepak, Dr. Sujala, Dr. Swarchala, Dr. Ramprakash, Dr. Meeta Sharma, and Dr. Charulata. I think all the delegates will have the wonderful take-home messages. Thanks to Kalpana once again, and thanks for the nice words by Dr. Amit Patki and Dr. Chaitanya and Dr. Shanta Devi. And my humble request to everyone, I am contesting for Foxy President this year. So all of you, please vote for me and nominate me from your societies. The election time is August 1 to 10. Thank you. Thank you. Yes, Kalpana, thank you so much.
Thank you so much, ma'am. Now we will move on to the first session, add-ons in IVF. I request Dr. Chaitanya Shembekar sir to take over from here. He will introduce the panelists. I will introduce sir.
I think
Sir
it's
is a
okay.
founder,
I think it's okay.
chairman,
We'll
and
start. No need to introduce. I'm just Secretary General of MSR now, and uh, we will start with the panel, right?
King of
So we
Nagpur,
have-
sir.
No. Thank you so much, Dr. Sampath Kumari. So, at the outset, I wish best of luck to Dr. Sampath Kumari for her endeavor, and we are always there for her. Team Maharashtra and Team MSR will be there
Thank
for
you.
you to support you throughout your journey during this another 2 months period. And we have a wonderful panel for add-ons in infertility, wherein Dr. Kedar Gandla is our expert. Then we have with us panelist Dr. Aditi Trivedi, Dr. Amok Chimute, Dr. Uh, Sheetal Savankar, uh, then Dr. Upama Yadav, Dr. Anuja Jeevan, Dr. Shalini Dwivedi. So these are our panelists. And without wasting much time, I think I should start with the screen sharing and start with the add-ons in infertility. This is a very interesting topic because we all are actually in our day-to-day practice at some or the other point using add-ons in our uh, fertility practice. So we must know the scientific evidence and the guidelines regarding the same. As we have already introduced all the panelists, I think Aditi is with us. Sheetal, you are with us.
Yes, sir. Amol is joining in 5 minutes. He just stopped.
Amog is joining. I tried calling him. His phone was busy. Upama, you are there?
Yes.
Yeah, she's
Yeah,
there.
Dr. Upama is there. Yes. And then Anjula is with us.
Yes, I'm there.
Yeah, great. Anjula is with us, and Shalini is also with us. Uh, Shalini Dwivedi. I think Shalini is
Shalini is
not
not.
with us. Whenever she joins, you just let me know. So we will start this panel, and I know we have a great audience. I can see the audience on the screen, and they all are, I know, interested in knowing more about the add-ons in fertility, and this is going to add color to our panel. We all know that we require a good endometrium and a good embryo for a good and healthy pregnancy. But if you have good add-ons, then it's a win-win combination, because unless you have a team, and this team includes the other people who are supporting the endometrium and the embryo, then only you will get a healthy pregnancy. So this is something which we are going to discuss today, the add-ons in fertility. If you just look at the latest ESHRE recommendations, which we will be discussing, we will be using this as a reference. There are 42 recommendations as far as add-ons are concerned, and none of the recommendation is high quality evidence. It says that of the 42 recommendations, none could be based on high quality evidence, and only 4 could be based on moderate quality evidence, implicating that 95% of the recommendations are supported only by low quality randomized control trials, observation data, professional experience, or CDG. That means we have only 5% evidence and 95% there is no evidence. So what you say, shall we go ahead or stop here? But then, as Kalpana madam has already told me to discuss this topic, I think we'll go ahead, because add-ons are here to stay, and you have to choose adjuvants in a smart way, and that is going to show your clinical acumen. So this is exactly what we are going to discuss in another 45 minutes. We will start with a very basic case, a case of overt PCO. As you can see here, her BMI is 30, her AMH is 8. She is a case of androgen excess, and now the name is also changed to PMOS. Her HbA1c is 6.4. She's 26 years, married since 6 years, IUI done 4 times, no pregnancy. So our expert has started, put her on IVF, and the clinician thought that REC-FSH is the best drug, and the clinician started with 300 IU of REC-FSH. And initially, it was thought that there is no need of adjuvant, so let us start with the REC-FSH. Embryologist says that 32 oocytes are opted, but only 8 are of M2 quality oocytes. And finally, on day 5, only 3 embryos were uh, of good quality. So here the question is, what went wrong? Embryologist says that oocytes are of bad quality. So can anyone tell us what went wrong? And because in panel we have to discuss the clinical scenario and we have to apply the knowledge of guidelines in our day-to-day clinical practice. That is the beauty of panel discussion. So we can start with I can see Aditi, because Aditi, you started with the calling everybody. So it is your honor. You should start with the
Thank
first question.
That's
What went wrong?
So basically, whenever a PCOS patient comes, she's age is on her side, egg reserve is on her side, but the most important thing is to correct the metabolic problem. Her HbA1c is high, BMI is high, and it's a very well-known fact that high BMI and metabolic disturbance does have an impact on the oocyte quality. So we shouldn't, in this case, she shouldn't have been rushed in IVF. First, ideally, lifestyle modification, give adjuvant to improve her insulin resistance, and suggest lifestyle modification, and after appropriate weight loss then take her up for IVF. And 300 is definitely high dose. You don't require such high dose when such
Yes.
age. So basically you start with minimal dosage, whether rec FSH or HMG. It has equivalent results. I think it was premature stimulation for this patient, I feel.
Right. So initially it was a man in a hurry took the decision to go for IVF and without thinking much started on rec FSH 300. So Aditi, what do you think should be the right dose in this case?
So it
With
depends upon the BMI, sir, but if it's a
Uh-huh.
lean PCOS, we even start at 112.5 or sometimes
Yes.
basic 150. In
Yeah.
today's day and age of agonist trigger and freeze-all strategies, even if we end up getting, because even 150 dose, you may end up getting more number of follicles. But with
Right.
agonist trigger and freeze-all, it shouldn't cause OHSS.
So less is more, right?
I
Here,
think. Correct.
more the
Absolutely.
merrier is not
And
what.
less the number of oocytes, better quality of oocytes you will.
Yeah. So we need eggs, not all the eggs. That is what
Right.
is the principle in
Uh,
stimulation. Yes, Sheetal.
Dr. Chaitanya, I think the BMI that you mentioned was 30. And
Yes.
again,
Yeah.
whether metformin was added or not is something that we don't know. The second thing that I think Aditi said is about the dosage, yes. But when the BMI is more, it is better because they have a high resistance. They might not get stimulated at all. So sometimes it is better to, I think, start maybe 150 or 225 also,
150.
like a higher dose. And again, I think Aditi rightly said that it doesn't matter whether you are using recombinant FSH or HMG, the response is almost the same, but the OHSS risk is lesser. So I think sometimes, even if you feel the risk is higher, yeah, it makes more sense to use HMG.
Yeah. So maybe 150 is the dose you have suggested. Yes, Upama.
Well, sir, also I would like to add that before like embarking on IVF, we should 100% give the couple at least 3 months of time to
Absolutely.
do her lifestyle modification and
Yes,
to
yes.
reduce at least 5% of the weight, which will cause a drastic difference. It will improve the oocyte quality and also improve other things.
So what we have come to the conclusion that give some time to the couple, focus on lifestyle modification, weight reduction, and then start with the adjuvants during this period, and then maybe you can go for the next step. Now coming to the adjuvants, uh, uh, which drug you think is the hero of adjuvants as far as PMOS is concerned? Which drug is the
Metformin.
hero?
Metformin is the best
Metformin
drug
is.
for this
Metformin.
disease.
Yes, yes. So Beshak,
Yes,
metformin is the
metformin.
hero. So there is no doubt about this that metformin is the hero in this case. And now I just want to know, anybody of you, have you ever thought of using metformin as an ovulation induction agent? And what is your experience? Metformin as an ovulation induction agent.
It is not a first line for
First
ovulation
line.
induction,
Yes,
but it is definitely helpful when you give it in combination with letrozole.
right. So, as Sheetal has rightly said, metformin is not the first line drug for ovulation induction, but at the same time, guidelines clearly mention that you can use metformin along with CC and now, of course, letrozole, because there is no doubt that letrozole is the.
It is more useful when used in combination with gonadotropin, not exactly
Right.
with letrozole.
So, what Upma
CC
is
resistant
suggesting.
and gonadotropins.
Right. So what Upama is suggesting is CC resistance is where you should actually go for metformin, and this is what we are going to discuss as we discuss more about PCOS. But this is the right approach. So metformin is the drug of choice. I just want to ask you, have you encountered this question in your day-to-day practice that, Dr. Sab, my father-in-law is diabetic and he is taking metformin and I am not diabetic, so why you are prescribing metformin to me? If somebody, a lean and thin PCO comes to you, she is just 24, her BMI is also not high, and she is, her sugar is normal, and then this is the obvious question which she'll ask you. So how do you counsel such patients? What do you tell them? And they will ask you that मेरी sugar तो कम, whether the sugar may go down and this may lead to hypoglycemia. So how do you counsel such patients? What do you do in your clinical practice?
So in these patients, we have to counsel about the effects of metformin. We should always tell them that it is your insulin resistance which is causing the problem, and this metformin will increase the insulin sensitivity and also decrease other things, like we can tell them scientifically also that it will increase your SHBG, and which will call decrease in free androgen index and other things. We can always counsel the patient regarding the effects.
Right.
And now with the new definition, sir, that it is not PCOS, it is PMOS. So it is like a polyendocrine metabolic disorder. So it is insulin resistance, and that has to be kind of taken care of.
Obviously, so this is how you have to tell them that no, you are not, I'm not giving you this for sugar control, but it is for a metabolic disorder, and this is not going
Yes.
to have its impact on hypoglycemia. It will not lead to hypoglycemia. It does not increase hypoglycemia in normoglycemic patient. This is something
Once
which you
we
have to
tell them it will help in weight reduction, she'll be more than
Yes.
ready to take it.
So you have to give the added advantage, or this is the brownie point which you should actually tell counsel patients that this is something which you are going to get. She'll definitely go for it, because there are problems with metformin. So we know that there is a problem with metformin. So how do you start metformin? And we'll go very fast because we have to cover many points. So how do you
We
start?
start with
Somebody
very
just
minimal
Low dose
doses,
500
and we will
milligram.
increase it weekly, because GI intolerance is always there in the patient.
so 250 milligram BD is the dose, and maximum dose, how much do you give?
Maximum
1500 to 2000.
2000 and
1500 to 2000, yeah.
Exactly. So 2000 is the maximum dose you can give. Now you just tell me one thing, which investigations you do before starting metformin? Do you do any investigations? जो भी है सच बताओ.
Sir,
Tell
मैं
me
करती हूँ
whatever you
fasting
do.
insulin.
fasting
I do
insulin.
fasting insulin.
Fasting
Okay.
और glycosylated भी करते हैं.
Yes, and
Because
HbA1c.
why I'm asking you, because the new guidelines of PCOS, HT guidelines say that there is no need to do
No
insulin
need.
levels. No need.
GTT
But
should always be done in all PCOS patients.
okay, so this is the beauty of panel discussion, because all the delegates, they will come to know what the experts are doing, and they will they will be following your guidance or your suggestions. So you say that you can do serum insulin and you should do, but though guidelines say that there is no need, you can do. Any other investigation you should do before starting metformin?
HOMA index. I don't
Sir,
know.
HOMA can be done,
is
but it
also
is not very
important.
helpful.
Yes. Yeah.
Okay, AMOG is
I
there. AMOG की
Lipid
entry हो गई है.
profiles.
Okay, yes, lipid profile, lipid profile,
Right.
HOMA. Yes. Anything else?
I do triglycerides for these
Right.
patients
Okay.
and lipid profile, fasting lipid profile. Since what I gather, the patient has a BMI of 30. So high BMI indicates that the leptin levels are also very high. So these leptin levels need to be controlled, and these leptin levels are going to affect your insulin levels. So insulin levels, HOMA-IR, and HbA1c are the three things that I generally do. Along with that, fasting lipid profile can be done for these patients to decide on what dose of metformin to start on with these patients.
Great.
So 250 for this patient might not be enough. We might have to
Yeah,
start her on
obese.
750
Fine.
BD or
500
1000 BD.
and then
Yeah, 500 BD. 500, start with 500 and then gradually increase dose.
Yeah.
I'll tell you the basic things. We know that diarrhea, nausea, vomiting, flatulence, asthenia, and indigestion, abdominal discomfort, headache are the common side effects of metformin, and that is why you need to counsel them properly. And the literature says that lactic acidosis is a very rare but fatal
Rare.
complication, and therefore it is said that almost all the patients who develop acidosis are having impaired renal function. And therefore, it is suggested that you should also do, apart from the investigations
RFT.
you have already told, LFT and KFT. So I think this is a take-home message we all should keep in mind, that start with the investigations you have discussed along with LFT and KFT, so that there is no confusion if the patient is having some gastric disturbance, and also if the patient is having impaired renal function, then she should not land up in acidosis, which is a
Acidosis. Yeah.
dangerous
So one
complication.
point I wanted to say about metformin is that whenever you tell the patient that you start metformin, you have to say that the side effects eventually go away. So as in they get used to it. And I think generally it's more bulky stools than loose motions and other stuff. So that is
Right.
what
So
I
proper
think I tell my
counseling is what is
patients.
important.
Very important.
And as Anjula Upma, you have said that this weight reduction is additional advantage which can help you in counseling. Here comes the algorithm for PCOS in CC resistant cases. We call it CC resistant. Now you can call it letrozole resistance. And this is where the role of metformin is there at the level of 1B if the patient is not responding. And you have rightly said that in resistant cases, it comes before gonadotropins. So in fact, you
Right.
should try this cheaper option of giving gonadotropins is a costlier option and you need more monitoring. So try 1 or 2 cycles of metformin and then only go for. Now comes the role of metformin in IVF patients. And can anybody tell me, is there anything specific as far as IVF is concerned in metformin? See, with metformin we are discussing for this patient who is, for maybe time intercourse or maybe after 2-3 cycles of time intercourse for IUI. But what about IVF? In IVF, anybody can tell me anything different
PCOS,
from
the most important fear of OHSS and the risk of there have been multiple studies which have been done and it's shown that if you use metformin with gonadotropins, the risk of OHSS also goes down drastically.
exactly?
Complications like preeclampsia, diabetes mellitus in pregnancy is also reduced. So metformin can be safely given even in first trimester of pregnancy. So
So
that
your
way it is going to prevent
okay.
that.
So your treatment of choice is antagonist protocol and metformin as an adjuvant in IVF.
Yes.
And the
Yeah.
guidelines say that you should stop metformin if it is not required or indicated after the pregnancy test is positive. So cessation of at the time of pregnancy test is what the guidelines for IVF say, and they have said that the dose can go up to 2,550 milligram daily. That means 850 milligram TDS.
TDS. Yeah.
So that is the maximum dose. Okay, so enough of metformin now. We go to the next drug, that is myoinositol. It's a new ray of hope. And I just want to know about myoinositol. Anybody can tell me about myoinositol, your experience. I mean, do you use it along with metformin or you use it in place of
If
metformin?
sometimes
What is the
So first
advantage?
of all,
patient
it is
does
a
not tolerate
nutraceutical.
metformin, we can give myoinositol, and 2 gram is the dose, and it really gives very good results. Very good molecule, actually.
So, Upama, you mean to say that if the patient is not tolerating metformin, you will switch to myoinositol, which is actually that is exactly what guidelines also then say, that it is freely available, cheap, and has got limited side effects. And that is the reason why ASHRAE also says that you can use myoinositol as a drug or adjuvants in PCOS. Now, just tell me about two important
Ma'am,
points.
sir,
Yes,
just
Amo.
1 minute before we proceed. I
Mhm.
have a different opinion.
Right.
Myoinositol will only work when the metformin is priming the GLUT4 receptors. Your GLUT4 receptors are the one which will take in the myoinositol. So to activate those GLUT4 receptors, you need metformin. So in patients who have high insulin level or insulin resistance, in such patient, myoinositol alone is not going to work. So you have to give
So now
metformin.
we have two indications for my metformin. One is where Upama says that you can give it if the patient is not tolerating metformin. You can switch to myoinositol. Amok says that you can combine myoinositol with metformin, which gives you better results. Now I just want to know about something which was very, it came as a very interesting topic of
Combination.
discussion, that was myoinositol and D-chiroinositol combination. And 40:1 was the ratio. Everybody was stressing on that. Suddenly, the pharma companies who were promoting this combination, they have disappeared.
Yes.
So, what is
the
your
Yeah,
take
reason?
on?
because
So actually, it
Because
increases the ovarian androgen production and impacts the oocyte quality as well.
quality.
High.
Yeah.
But I think 40:1 is the combination. Very high PSI level is hazardous. Myoinositol especially works in patients who are lean PCOS who don't have insulin resistance. So that helps in improving the oocyte quality, especially in patients lean PCOS who are taking up for IVF.
So if I want to go into the biochemistry of it, D-chiroinositol is a product which is a byproduct of myoinositol as well.
Right.
So until unless your myoinositol is converted to ITP, it's one of the byproducts is D-chiro. So force feeding D-chiro-inositol in a cell which is already producing is not going to be very beneficial to that particular cell. And hence that is causing all the problems with the oocyte quality. So you're force feeding a molecule which is already being produced and which is not being taken up by the cell naturally. So that is why the combination of myo and D-chiro is not a rational one.
Sir,
The
actually,
dosage
myoinositol
can be
and
40:1. So
so myoinositol and metformin both have different pathways. One acts on PI3 pathways and other on AMPK pathway. But they both increase the insulin sensitivity. So when they were used in combination, they both synergize each other's action. And
Exactly.
even
Synergistic action. Right.
So it is
But
not
the
crossing.
role
You
of
can give the
DCI,
combination. I agree. And the only thing is that DCI in higher doses creates a problem. So MI and metformin is a good
yes,
combination.
Yeah,
yes,
it's a
now,
I
good
agree with Sheetal.
combination,
Yes.
and
so,
especially
so I think,
we
yes, Anjula.
yeah. So especially in candidates where like I screen out that previous there is a poor stimulation quality despite of high AFC also. There's one candidate we can have always been doing it, and then previously if there is a immature oocyte predominance, so that is how like you decide for the combination according to the case, like insulin resistance and then elevated fasting insulin and things like that.
Okay, so moral
That
of the
is, yeah.
story,
Yeah.
the take-home message is very clear. What is trending nowadays is myoinositol metformin combination, and the myoinositol D-chiroinositol combination is taking a backseat because of some controversy over it, which Amog has explained us in a nice way. So we now go ahead with this take-home message that this is the trending combination, and we should stick to this combination. Now, I just want to know. There are so many adjuvants which are there along apart from these two main adjuvants in PCOS. I just want to know there are glucocorticoids, there are statins, there is N-acetylcysteine. So many drugs are there. How do you decide? I'm not going to go into details of any of this, but I just want to know how do you decide, or you just give blanket all adjuvants to all the patients? How do you decide? What is your criteria for deciding the adjuvants in PCO?
So I think whether it's PCO or it's poor responders, I think CoQ10 should be given because the problem is with the oocyte quality. So
Yes,
CoQ10
so
I think should be
CoQ10
given
is
to all
everywhere.
patients.
It is for male
Everywhere.
infertility also, Sheetal. So for
Absolutely.
DOR, for and ऐसे भी दे सकते हैं
ऐसे भी
oocyte
दे सकते हैं.
so it is everywhere. So there
Doping
is
के लिए भी दे सकते हैं.
yes, so
CoQ10 is for
no
mitochondrial
controversy.
enhancement. It acts on the mitochondrial level. And for metformin, we do it should be IGT impaired glucose tolerance. And for glucocorticoid, there should be higher DHEA. In those patients, we can give.
Yes,
And
yes,
statins, if she has a history of some hyperlipidemia or other things
right.
on the testing, then we can give.
So at high DHEAs, we can use steroids, very rightly said. Then we will just go for this. If the delegates can take the screenshot of this slide, because this is a very interesting slide where in this study they have discussed everything, like including all the other associated factors like anxiety and depression, psychological disorders, obesity, and what all adjuvants you can give depending on the situation. Elevated homocysteine levels, hyperandrogenism, hyperinsulinemia, dyslipidemia. So everything is nicely explained in this flowchart, wherein every part or every aspect of PCOS is taken into consideration. Before we move ahead to the next case, I just want to ask you a very important question, because we are talking about add-ons. Pre-treatment also comes under add-ons in fertility. And if you look at the latest ovarian stimulation guidelines, they have given 5 add-ons in as a pre-treatment for patients of infertility for IVF. I am focusing on only one pre-treatment, that is OCPs. I want your opinion, because this is all the panelists, they know, and all the delegates also know that high LH level is an important point in PCOS, and it is a age-old teaching that OC pills reduce the LH levels, and therefore OC pills are good for PCO patients. What is your take on this? Will you advise OC pills as a pre-treatment in patients of PCOS with IVF? for IVF. We are
So
planning
if the
ovarian
LH
stimulation.
levels,
Never. We
so
do
if
not
the LH
prescribe
levels are
ossipils.
high,
One
only
by one we
then
can take
that will
Shital.
be.
Yes.
Yes,
LH
so
levels
if the
are high.
LH levels are high, only in that case, maybe you can think about giving oral contraceptive pills. But again, the duration of OC pills should be limited to 10 to 12 days because otherwise there's going to be too much of pituitary suppression and then maybe the agonist trigger might not act. So that is something that we need to
Very
remember,
well said,
especially in
Shital.
donors.
Very well
Yeah.
said. So maybe you can give short course if LH levels are high, but otherwise no.
No.
Upama, you wanted to say
We
add.
do not worry about the LH levels in PCPMS patient because they are tonically high. And
Okay.
when the other things
So
will
we are
suppress,
not worried about high LH levels. Okay.
Hmm.
Anjula, what is your take?
I think excessive suppression may reduce the endogenous LH surge responsiveness. So
Exactly.
potential, So potentially it influence the one can call the trigger dynamics.
Absolutely.
So that is why the evidence takes a caution on a routine OCP pre-treatment.
Aditi?
Practically, sir, just the fear of the agonist trigger not working, we have stopped using OC pills. Especially, it's very important to take history of the donors because most of the
Donors,
donors are on
absolutely.
long-term
Yes,
OC
yes,
pills.
yes. I think this is
Yes.
very
So,
important because see,
yeah.
in donors, we categorically tell bank people to give GnRH agonist as a trigger,
Yes.
or we
Yes.
also give only agonist as a trigger. We don't want to take any risk. We don't give HCG as a trigger. No HCG, no Vitril, only and only GnRH agonist. And all these patients, they are on OC pills because OC pills is the most popular down regulation drug which is available in India, and everybody is on oral G. So in that situation, I think this is the most important take-home message for all the delegates who are attending this webinar, and especially the young delegates. Please keep in mind that it will suppress the HPO axis, and this will have negative impact on agonist as a trigger because the ideas are very clear: antagonist protocol, agonist trigger, and freeze all policy. That is what we do in PCOS, and in
So
that
this, so,
situation,
the,
there is a
so
strong
then what
recommendation.
about batch? What about the batches? Most of the batches
If at
use
all,
OCs.
so if at all you have to use, you can use estrogen priming or
See, this
else you
is
can use
yes, Aditi.
medroxyprogesterone
See,
because
I am
that will
giving you
bring in
all the
uniform follicles.
yes, Aditi. I am giving you list of 5 pre-treatment drugs which are given by the estrogen guidelines, and out of these 5, first 3 are actually used only for. See, even antagonist is also used for only for adjustment of the scheduling of the IVF.
Cycle.
That's all.
Right.
Scheduling of
Right.
IVF. It is
Scheduling
they
of
have
IVF and also like follicular asynchrony
Asynchrony. Yeah.
Absolutely.
have
and
clear.
and even for cycle organization issues also.
So
So
it
So
is
many a
clearly
time,
mentioned.
many
Clearly
a
mentioned that
times,
all.
a donor comes on just day of period, and we
Hmm.
need to recruit her. She has not taken anything previously, neither estrogen, no progesterone, no
That
OCP.
antagonist.
If we wait for 1 month, they will go to some other center. So we usually give 2 days of antagonist and then
Exactly,
vaccination.
exactly. So here comes the role of antagonist. So they have said that all these drugs are used for scheduling of IVF, and since we are not discussing scheduling of IVF, all the drugs are not recommended. Not recommended, but special mention about OC pills. So please keep in mind, do not give OC pills, and this is a strong recommendation. Otherwise, they say that may be used, can be used, but here they have clearly said that you
No.
should not use it because
Not
it
okay.
reduces the efficacy. Now we quickly move on to the next case, and this is a case of a young girl who is married since only 2 years. Her age is 32. She's planning pregnancy. She just comes to you for preconception counseling, and you just ask her to do her image, and her image is 0.7. Now, how to handle this situation? If you bluntly tell her that, अरे तुम्हारा AMH तो इतना कम हो गया, तुमको donor program को जाना पड़ेगा. So she will, she will get, she will be depressed, and she will be morally, down, and in that situation she may not come again to you. So what is your approach? How do you manage such cases?
So
Everybody wants Onyx.
she is a young patient, sir, and she's Poseidon Group 1 she belongs to. And we can always definitely
Maybe
give
3,
her
maybe 3, yeah.
3.
Poseidon Group 3, yes.
testosterone.
3.
We can give her DHEA, actually,
DHA.
and she
Yes.
might
So
improve
how do
because her
you
age is on her side, and
yes,
we just want even 2-3 follicles. If she get, it will be good enough.
right.
So I have a
We should
counterpoint to
not
this.
count the number of
Maybe the
follicles, but quality. If we
AMH,
improve, then she might get pregnant.
maybe the AMH is also wrong. So without doing a AFC, we should not only rely on the
So there
AMH
are
level.
two ovarian
Right.
reserve testing which are alone are sufficient to do the ovarian reserve testing. One is AMH and second is AFC,
Random
and the
AFC.
two should be always be taken together
Correlating.
because
Yes.
अपने आंखों पर विश्वास रखो. Please
AFC.
believe in your clinical acumen. You believe in your ultrasound expertise instead of believing relying on the lab.
Sir, and if I may, one more thing. Many times a large endometrioma will also compress the ovarian. Many times you find that the AFC is 15 and 18, but the AMH is less than 0.5 or 0.7 or 0.8.
So these
In
are the
such
practical
situation, again,
points. Yes, you may miss that. So unless you do FC, you should not comment on AMH. This is one thing. Second thing is this is something which is eye opener for all of us. A very famous paper from Fertility and Sterility which says that ovarian
yes.
age in India is 6.3 years ahead of compared to Spanish women. So I know Sheetal Aditi may not agree with me, but I have been telling this to all my patients
So in
that
fact, menopause is also at
Menopause.
41. For
Yes.
Caucasians, it is 45, 47, 48. So
to
our
get married
average
early
menopause is
and have
also early.
have at least one kid before 30. That is what I have been
So
promoting.
we
But
can
then
do oocyte freezing.
yes, I was expecting this answer from you.
There are so many
So
options.
yeah, and I think you should I think you should have open mind and you should have open approach. Whenever patient comes to you, don't go with the conventional counseling के बेटा जल्दी शादी कर ले, हाथ पीले कर ले और जल्दी बच्चे पैदा करो. You can give them option of oocyte freezing also, and that is actually something which is coming up in a big way even in tier 2 cities like Nagpur, Shital. We have every month we have 2-3 patients of oocyte freezing, and they are coming from small
Yeah,
towns like
small villages
Varda,
and towns also.
So
Yes.
Hinganghat,
I'm
Varda.
glad. Finally,
Yes, yes,
it's
yes.
happening.
It's happening, and we are also respecting their sentiments. And that is what
Yeah.
you should do. As a good clinician, you should respect their sentiments, you should listen to them, and also try to understand what they want in life. Right? Now that we are, as you have rightly said, DHA is something which can be given. Now, I just want to know the funda of 3 months. Every time we say that DHA for 3 months, metformin for 3 months, what is the funda? Why this 3 months period is important for all the adjuvants for that matter? Most of the top adjuvants they are given for 3 months, especially metformin and DHA.
Sir,
Because the
whatever
recruitment of
adjuvants
the
we give is
follicles,
not. Sorry, ma'am. Please go ahead, please.
Yes, Upma.
sir, because the recruitment of follicles take around 180 days. So we should always take care of those follicles which we are not even seeing on ultrasound, which we are not even counting.
So I think delegates and those who are young delegates who wish to learn more about IVF and infertility should take a screenshot of this famous diagram, which actually says that there is something called as gonadotropin independent phase and gonadotropin dependent phase. We know the physiology of ovulation. We always talk about the day one of the menses. We always talk about the small anther follicles becoming one follicle becoming dominant, and then there is ovulation. But we also should know that there is something called as paracrine control, and this paracrine control starts from primordial follicles to primary follicles to secondary follicles, which become small anther follicles. And this is the period where actually the adjuvants
Adjuvants are
all work
right.
very well, and that is the reason why we always. And so in this case, the case which we are discussing, you give some time to this patient because she has just casually she has come to you just to know about she's thinking of planning a pregnancy. So thinking of planning, in that situation you should give her time, and this time can be utilized for as lifestyle modification. It plays a role everywhere, not only PCO, not only obesity. Everybody needs physical exercise, mental peace, and these are the things which are essential for our day-to-day life and in infertility in particular. So you can utilize this time for giving DHA along with other thing. Now दिल से मुझे बताओ, DHA is the most popular drug. What is your experience about DHA? Is it just one more addition to all the the drugs which are already available in the market? Because in US, DHA is available over the counter, and all the not so young girls in their late 40s, they actually use DHA regularly for, good as it's a mild androgen, so it helps you in tiding over the menopausal symptoms. So, do you think that DHA really works, or it is just a hype, or is it a miracle drug, or it's a hype? What is your opinion?
I think even by ASHRAE guidelines, they have said that one of the adjuvants that has some role is DHEA. So I think poor responders or DOR, I think poor responder is out. So DOR patients, I think we should use DHEA. Again,
Sir,
in combination with antioxidants like CoQ10. So these two things are something that we
Sir,
should definitely use.
So in patients who are less than 35 years of age, we can give them DHEA, and who are more than 35, we should give them directly testosterone gel.
Right. So House is very clear about one thing, that DHA should be given. Now, have you ever done AMH levels after DHA after 3 months or something like that? Frankly speaking, I have never done that. But
I have
do
also not
AMH,
done.
but they're evident on ultrasound only. Where follicles, the patient starts responding.
Upma, do you find increase in the AFC?
Not increase in FC, sir. They start responding to the gonadotropins.
Yes.
So what DHA does is also improves the oocyte quality.
Yes.
Right.
Because
Yes,
your
yes.
So it improves the oocyte quality. It reduces the abortion rates.
Yes, decreases miscarriage rates.
Yes, so that is how it works. And even our own Padmarekha Jirke, she was chairperson last tenure. She is immediate past chairperson of MSR, and she has also done this study where she says that DHA works and it works very well. And now we come to the other adjuvants apart
So
from
in
DHA
fact,
here.
a combination of DHEA and testosterone can also, the gel can also be used for some time
So
because they have
why not
different
use?
actions. Yeah, I do
Yes.
use it. So it is a
So
very
why not
good
use combination?
combination.
Yes, yes.
Yes.
So this is what we are discussing, and what is your dose and when you start, and what is your protocol of testosterone gel?
So that is one pump, that is 12.5 milligram, 1% testosterone gel. That is like a thin layer is supposed to be applied, and you have to tell the patient not to keep wiping it. It's just one stroke, and that is good enough.
And when you start, and how much is
So then in DHA,
duration?
you need a duration of around 2 to 3 months, that is 3 months. But in testosterone gel, they say that even 21 days. So sometimes when the patients say that, no, we have to start the cycle, especially with very low ovarian reserve patients, I think testosterone with a 3 weeks period also, when you're preparing for IVF also, I think it's a good enough drug.
Yeah, with the permission of Dr. Rajesh Koradia, I have taken his slides, which are all of us know they are very popular slides. But I have taken his permission, and this is something which the protocol which he has given, where previous cycle ovarian priming is done with the help of testosterone gel. Alternately, he has given, I don't know, some third day, fifth day, seventh day. So there are so many protocols. But what I do is I start from maybe 15th day of cycle and give it for 15 to 20 days. And this is what Sheetal is also mentioning. Anybody differs on this?
No.
Right.
So
We all
I
I
use the
don't
don't
same
know
think
the
so. I
protocol.
logic.
think everybody
So
is
I
saying.
don't know understand the logic of alternate day because the
I
dosage is
also don't,
for
I also
every
don't
day
understand.
thing,
Yeah.
But
and
yes, but then
nobody's
every day you
mentioned
can
this.
give. Right. So you can
Yes.
give every day for 15 to 20 days. That's all. But you should give. And now we have coming to the conclusion that this synergistically it works very well. And that the DHA can be, supplemented with testosterone as the day of IVF approaches. And what about growth hormone? Because I remember because we started IVF 22 years back. During that time, growth hormone was very popular. But nowadays, I don't know. When I talk to people, I don't think many people are using growth hormone as an adjunct. So, but anybody having any experience
So
with growth
I
hormone?
use, so I was
Yes, sir.
not using it, sir. I started using it. So it has two things, sir. It also improves the endometrial receptivity. Now, in patients with DOR, we also think of doing fresh transfers. So in that case, also it helps to improve the endometrial receptivity also, and I think it kind of gives good quality oocytes also. So I think 4 milligram dose is good enough. 4 IU
For
dose,
I.
maybe from the
Okay,
second
4
day
IU.
of stimulation. 4 IU,
Because
sorry.
most of them
What
said
I
they 8 IU. I don't know.
So
discussed
Okay.
with
4 IU
Dr.
is good enough. Yeah,
What
it's
I
Okay.
good enough.
discussed with Dr. Firoza Parekh madam was also that you should start it ideally in the luteal phase and give
We
it
can do
to
it. There
the
are two
day of
protocols.
trigger.
Yeah.
It works
Yeah.
better.
Right. So
Yeah.
you can give it. So if you just look at if you are reading textbooks like Gardner, So if you read Gardner, you will find that Gardner has said that out of the many meta-analysis, they have said that growth hormone is
Works.
one of the interventions which works very well. So he has actually promoted growth hormone, but and this is again the protocol which is given by Dr. Koradia sir, where he has used a growth hormone 8 units per day from the second day of the stimulation up to the day of trigger. But as Aditi has rightly said, you can use it for during luteal phase of the previous cycle also, which will help you in improving the oocyte quality. What about cost factor, Sheetal?
That is what. So I was thinking that especially when we use it in the previous part, it's said to be started at least 2 weeks or 3 weeks prior. So the cost factor goes up too much. So I feel that maybe during the stimulation, it is a little better. And again, as I said, it improves the receptivity also. So it's a win-win.
During our childhood days, especially I remember those days, Amitabh Bachchan was on top, and people used
Yeah.
to say that Amitabh Bachchan is the boss, but गरीबों का अमिताभ बच्चन है मिथुन चक्रवर्ती. आज मिथुन चक्रवर्ती भी बहुत बड़े आदमी है. He is a very good actor, but we used to say that गरीबों का अमिताभ बच्चन कौन है? मिथुन चक्रवर्ती. So similarly, गरीबों का growth hormone क्या है पता है क्या? गरीबों का growth hormone है pyridostigmine. This is available as 60 milligram tablets, and if you give it BD from ovarian stimulation up to trigger, it also works very well. I have tried this, but I'll share my experience. I was very happy initially because we used to get, especially DOR patients, we used to get very good follicles, and I was very happy. But then I found that most of the follicles were empty. So I thought that it's not working, so I stopped using it. But initially for 6 months or so, I had tried using pyridostigmine, but I realized that it's not working, so I stopped using. But anybody
So
having
how does
experience
it
with
come? I
pyridostigmine,
have no experience. So how does it come, like a tablet or how?
it's a tablet, 60 milligram
Pyridostigmine
tablet.
I have not used it ever.
MTPD. So you can try that if your patients are not affording. But then I have come to the conclusion that both growth hormone and pyridostigmine, I am not using it, but Sheetal has experience with growth hormone. Nobody has experience with pyridostigmine, but
No.
I have experienced it, but I have stopped using it. Now, I think I'll skip this because HCG, low dose HCG is, there are so many other drugs which are available. Which you think is the most important Poseidon group for all of us in our day-to-day clinical practice?
Toughest to treat?
Group T.
Yeah,
Yeah,
see,
group 4. I think group
Four.
4 is the
nee,
toughest.
but for which group you have where you have most sympathy, or you can say empathy, for which group you have empathy?
Group 1, sir.
Group 1, Group 1.
I see. Group 1 and group
Group
2
3.
is something where you stimulate
Group
and then
3.
you don't
Yeah,
Group 3.
I
Young
think
young with
young
poor
piece,
ovarian
yeah.
reserve. Young with poor
I
ovarian
always
reserve.
have empathy for group 3 Poseidon group
Yeah.
because
Agreed.
they are young.
29-year-old with hardly 2 or 3 follicles.
Yes,
Follicles.
they are
And
young,
that is
but
the
still their MH is
commonest.
low.
And commonest, sir. Nowadays, we are just seeing
Yeah,
those
yeah.
kind of patients.
So many patients you come across the 28, 27 with 0.3, 0.4. So I have full empathy for them. And you all should also see anybody coming to you at age of 39, you can say that teri to age ho
Yes.
gayi hai,
हाँ.
you are already
You can go for
39.
a donor.
Convince, they will not agree. Now nobody agrees for donor, that's
Um,
okay.
So,
Initially
but
at least.
one thing is Poseidon 3, because they are on the younger side, pooling and these kind of things work better because even if the ovarian reserve is low, the quality of the oocytes is better. So that's the
Exactly.
only catch point.
Exactly, and that is how you should counsel them. See, you have to, counsel them, and you should make them feel comfortable because they are already upset. Actually, today only I have counseled 3-4 patients. They read everything. ChatGPT is now available with us. They will immediately put my age is 0.3 and my age is, so what should I do? And they are devastated. They are so depressed, and they'll come to you. So your duty is to counsel them. What Sheetal has said rightly, that age is on your side. So still you have time, and don't dishearten, don't get depressed. In fact, you should always think of pulling also, and you will get results. So this is how you should counsel them. And for me, Poseidon group 3 is important. Now, as we have already discussed, antioxidants are everywhere. But if you just look at the guidelines, they are very blunt. They will say that antioxidants are not recommended by
Not
HRA.
recommended.
Adjuvants like metformin, growth hormone, testosterone, DHEA, aspirin, indomethacin, sildenafil before or during ovarian stimulation are not recommended. So baat khatam, kissa khatam, story khatam. But still, as we all know, we are using it. How much time we have? Should we stop here or 5 minutes? I don't know.
So we should
Organizer.
talk about ovarian PRP. I think it's important. So
Yeah, organizers. How much time we have? We started at 7:20, I guess. 6:20. What time we started?
I
I
think
think
6:15.
6:15. Yeah,
6:15.
6:15.
6:15.
5 minutes?
Yes, sir, you can carry on, sir.
Okay, thank you. So yes, now we have this ovarian PRP. I just want to know the experience about root of PRP and results of PRP.
So ovarian PRP, I think whenever you're doing it, you have to tell the patient it is an experimental thing and you have to take the consent accordingly. That is one thing. Second is vaginal route is the best route. Uh, I think last time when Amog and I were on the same panel, he spoke about a very nice needle for an ovarian PRP. So I think that is something because we generally use the normal needle that we do for oocyte aspiration, but he spoke about a very cheap alternative. And I think that is amazing
Yeah,
because most of the times with ovarian PRP, with the oocyte aspiration needle, there is a backflow. With what he had suggested, if
Yes.
he can speak about it, it will be great. So I
Yeah,
think in some patients, it does work well,
yeah.
Ripulin?
especially patients, yeah.
So I use
Yeah.
a very simple ovarian cyst aspiration needle which the radiologist use. I apply a three-way cannula to it and then use it and put it through the 18 the needle guide.
Amok, there is a needle called Riprolin company needle, which I prefer in many situations. Why? Because Riprolin needle can be disconnected from the base.
Yeah,
Base.
so even the cyst aspiration needle, we need to put a three-way cannula to it. So there is no backflow, and your assistant can also push. The assistant can also hold. So it is not a single person procedure that you have to prevent the backflow with it, and then do
Okay,
all the
so
juggleries with the
that
spillage. So
can
this
you
is a very cheap alternative.
share with us the name of the company or needle?
I'll just
I
And I
have
think
share
it's
over
just
with
experience.
you.
60, it's very cheap also, na Amog,
Yeah, yeah.
the one which
It's
you spoke
hardly
about.
it's
Okay,
hardly 100
you can
110
tell
rupees.
later, but then
Yes.
I have a experience with Riprolin needle. Riprolin is a good
Hmm.
needle. You can try
Okay.
that also. Because you can attach syringe directly to the needle. That is the advantage.
So what I
Now,
usually do is I do it generally with the first oocyte retrieval, so the patient doesn't have to undergo anesthesia. So first pickup, because we are also worried that the ovarian reserve is going down, I do the egg retrieval, and that time the ovaries are also slightly bigger. So that
yes.
is the time I do the oocyte ovarian PRP, and then obviously wait for 1.5 months, and then do the second egg
So where
retrieval
do you inject when
in
you're
the
doing a pickup
ovaries,
in
in the
The
where the
ovary.
yeah,
medulla or the cortical region?
the cortical
Cortical.
region.
Cortical.
The cortical
Cortical
Yes.
region
region.
will be very thinned out, and there will be leak of PRP.
Yes, yes,
Then
that anyways happens.
that can create a chance
So,
of peritonitis also.
what I gather from your discussion is that you, Amog and Shital, you are doing ultrasound guided
Yes.
PRP.
Yes,
Anybody
yes.
for laparoscopic PRP?
So only in patients with very poor ovarian reserve, where the ovaries are not accessible and very high up, very small.
Hmm.
In that case, laparoscopy will work, but otherwise we can easily do it ultrasound guided and
Ultrasound
prevent
guided.
procedure.
See, there is always a possibility that, as you rightly said, ovaries they are very small, and if they are small ovaries, and you may find difficulty in getting the ovarian cortex, and in that situation, maybe laparoscopy is a good option. And another thing is, if you are anyways doing laparoscopy, uh,
Hmm, hmm.
during that time, you can definitely go for ovarian PRP.
Yeah.
So, Angela, your take on this?
Yeah. I've been doing with transvaginal PRP only, and the response has been like patient to patient, it has varied.
Mixed.
So it's
Upama?
a mixed reaction, and basically it was I think the patient should be given that it's a experimental this thing.
Very
So
important.
yeah, that's very important. The
Upama, your
counseling
take
part
on
is
this?
very.
Sir, I always advocate laparoscopic PRP only.
Okay. Done. So,
But
most of the
laparoscopic PRP, generally PRP requires 2 sittings at least. What I have gathered
Yes,
from
one
the
thing.
2 to 3 years of doing this, at least you require 2 sittings of PRP, and doing laparoscopy twice just for a
Yeah.
PRP is taxing on the patient more on the wallet as well as the patient's mental health as well.
Surgical procedure risk is always there. Okay.
Yes.
Now
Yes.
we will discuss only 2 points. I just want to know, see, PGT is something which is now beyond doubt. It is proved that PGT is a good option, especially for, the age is say around 38 or more. So Munne et al. Has done many studies and they have clearly mentioned now even guidelines are talking about PGT as a good add-on for improving the results in patients with DOR or with RIF or patients with RPL or patients with advanced maternal age. I just want to know about the non-invasive PGT or NIPS.
No.
So
The concordance is very
NIPS,
poor
It does
and the
not show
positive
good
predictive value is
results.
also very poor.
so all
It
said
doesn't
and
show
done,
good result
no,
also.
Yes, sir.
all said and done, I think sometimes we have to do, and I know even ISAR has said it's a big no, but I think some patients where there is already the oocytes are weak, in some patients where you can't even, like, they are cavitating embryos, I think sometimes PGT also, if required, I think it can be used as an
But in
alternative.
if the embryos or the blastocysts are not of good quality, then better not transfer.
Among,
If they are
we've
not not a
all
very good,
agreed to this situation
yeah,
that sometimes even with cavitating embryos and compacting embryos, patients have become pregnant. So I think
yeah,
that's a
true.
chance that we
Only,
So
can
the
give.
only
so
in
I think
RIF or RPL patients, we can recommend, we can give the choice to the patient also. Counsel.
Absolutely. We can always
Yeah,
tell them
so
that
Upma,
there's
you
a
can talk about
percentage of.
you can tell them about NIPGT also. That is what
yeah.
you want to suggest. Okay. Now the other day I was listening to Dr. Manish Bankar and he told something which is I found it very interesting. What he said that see the embryo is growing in the media, and when the embryo is growing in the embryo has a tendency to throw all the negativity outside into the media. So the media is full of something which is having aneuploidy or whatever, and the embryo is good. So if you take the media and do non-invasive testing, you will invariably get aneuploidy or some results which are
So it is the
not
excreta of the embryo.
expected. Exactly, it is the
Excreta.
excreta of the
Sir,
embryo,
sir,
and this
that
is very
way.
interesting. I don't know whether it is true
So
but
you tell
then
me, even if you are doing the invasive PGTA, that way, if you just pick the bad cells, that way also it will come as high mosaic. So I think that is a possibility in both the
but
situations.
this is interesting. Yeah, we all
Yeah.
should
Yeah.
keep in mind that embryo is throwing out all the negativity and trying to,
So practically,
be
I
good.
agree with Manish sir
If
because
we have very less embryos, there is no point in doing PGT because even otherwise we will have to discard those embryos. Better to transfer and then see the result.
So now
I
last,
think I agree with Dr. Upma.
okay. So the last question is, why do girls marry?
Legitimize the children.
The
You
answer
need
To
is
just
someone
have
to
a,
blame.
yeah,
You
you
need
cannot
yeah.
someone
blame
to
government for everything and anything happening in your life. You need husband. And somebody, when I was asking this question, somebody said this is true for husbands also, for the boys also. So, but whatever, all said and done, immunology or immunological aspects of RPL, RIF, everything is something which is now coming up in a big way. It's just like passing the blame game. And here you consider embryo as a graft. I just want to know one last point because we are talking about late and we are talking about everything. But I want your opinion about a new kid on the block that is thymosin.
Thymosin.
Yes, I just want to know
I am using
thymosin as an
thymosin, sir.
By
add-on.
using thymosin
RPL
only in
and
RPL and RIF cases.
RF patients. And it
Okay.
works really well. As
And
in,
RPL and
yeah,
RIF.
mm.
it gives good
Indication. What would
results,
you
sir.
suggest? Indication RPL as in what do you see in endometrium? Many times because you get a good triple line and 5-line endometrium, and still you have a failure. Is thymosin going to help in that? No. What you need to find out is there an underlying subclinical impaired inflammatory state of the endometrium?
So Amok, I
So
just want to
thymosin is
know,
not going to that is
Amok,
not going to correct it.
Amok, I want to know battery of investigations you advise to the patients before. See,
TH1,
there
yeah.
are 2 3 things. One is you have to counsel them, you have to
Yeah.
give them option, but at the same time you should have some base or basis for advising or going for thymosin. So what are the investigations you do and how do you interpret them?
So I don't believe in thymosin alpha.
Okay.
I've not used
So
it,
you don't use
but
it. Okay.
so
Then
what I do is
immunoglobulins,
I do
IVIG.
do a hysteroscopic targeted biopsy, especially if it is showing an impaired inflammatory state. Check the CD56, check the CD138, BCL6, BCL2. Depending on what is coming positive, you need to treat that condition, because BCL2, BCL6 coming positive together is a different story altogether. CD56 is different story. CD138 is a different story. So all have different factors. These factors are going to cause different reasons for implantation failure. So you need to treat that. Thymosin alpha per se, just using as a blanket treatment because it is the new kid on the block, it has no rationale according to me. I don't know what the guidelines say.
Anybody want to add something? Yes, yes.
So I agree with Amok.
Even IVIG give good results, sir.
No, about
Ma'am,
the
but what is the
thymosin
indication of
also.
IVIG? IVIG, are we investigating the immunology of the patient? Are we doing APLA and ANAs and RA factors for all patients before India? Then
Only in those
prescribing
But we are
IVIG.
talking about RPL and RIF patients, no, Amok. We
only
are
those
talking
That is
only
what I'm
about
saying.
those patients.
are
We don't
only
give
those
thymosin in all
patients.
patients.
In RPL and
Also,
RIF also,
sometimes, no,
many times you don't
sometimes.
get anything positive, still we give IVIG. That is something which is just a empirical thing कि अच्छा कुछ काम नहीं कर रहा है IVIG दे दो चलो thymosin दे दो. Is there any
IMIG तो
rationale
सभी
to
को
it?
देते हैं.
Like
But
we give progesterone in all forms.
So what is the take-home message? You should investigate the patient.
Yes. You
And
need
if
to check you need to check the immunology of the patient
immunology of the patient and
the endometrium, not just the patient.
Okay.
Sorry
Now
to interrupt, sir. We are running
Yes.
short of time.
I am
Yeah.
finishing.
Thank
I
you,
am
sir.
already done. So I think this is a song which tells us about everything which we have discussed.
Yeah, wonderful.
Thank you very much. तो
Thank you so much,
जिंदगी
sir.
हर कदम एक नई जंग है जीत जाएंगे हम
Thank you.
एडवांस अगर
Thank you
संग
so
है
much.
Thank you so
Thank you.
much.
Wonderful
Thank
panel,
you.
and
Yeah.
I enjoyed discussing this interesting
Wonderful
topic with all the
moderator.
panel.
Thank you. Thank you.
Thank you so much.
Thank you,
Bye.
everyone.
Yeah.
Bye.
Okay.
Bye all the
Bye-bye.
time.
Bye.
Bye-bye.
Thank you. Bye.
Yeah,
Would
that
like
was a
to
wonderful
thanks Dr.
discussion.
Kalpana also, ma'am, because for giving me the opportunity.
Yeah.
Yeah.
It was really wonderful discussion initiated by Dr. Chaitanya and experienced by all the panelists. And we started with politics and ended in dance. Excellent panel discussion. Let's move on to the next one.
Thank you, Kalpana.
Dr. Varsha and the panelists are waiting.
We'll move on to the next session, optimizing outcomes in PGT. I welcome Dr. Varsha Samson Roy as a moderator for the session. She's a head embryology in Birla Fertility and IVF Center in India. She has over 25 years of experience in the field of ART. She lead the embryology team that succeeded in the birth of India's first in vitro maturation baby in July 2003. She's credited with the birth of Karnataka's first
Sorry to
vitrification.
interrupt, Dr. Sharon. Just to save time, can we skip the CVs? It would be good.
Okay.
You can just introduce the people in one line and we can proceed if that's fine.
Yeah, I
Dr.
welcome you,
Varsha, if
ma'am.
you want, you can introduce in a short manner and invite them because you might be knowing in a better way rather than.
Sure. So, no, we can have the CVs, Dr.
Yeah,
Sharon,
CVs,
and
yeah.
introduce them. Yes. So, thank you so much, Dr. Kalpana, for giving all of us this opportunity. And thank you, Maharashtra ISAR, for having all of us here. And uniqueness of this second panel is that we have all embryologists and geneticists on this panel, and hence we're trying to make it interesting for all the clinical audience here. So we have Dr. Priya Kannan here. Dr. Priya Kannan is a very senior embryologist. She is also the lab director at her center. We all know at Garbha Rakshambige. We all know Dr. Professor Deepak Modi, a very well-known scientist at the ICMR Molecular and Cellular Biology Laboratory in Mumbai. Extensive work of his is well known and well published. We also have Dr. Sujala, who's a very senior embryologist at Birla Fertility. She's also a cluster head with extensive NIST certified embryologist with extensive experience in embryo biopsies. Then we also have Dr. Ram Prakash here. He is also a very senior embryologist, huge experience in PGT, embryo biopsy, and IVF cycles. We also have Dr. Suvarchala, who is the scientific director of Ziva Group of Fertility Centers. Dr. Suvarchala has also done her clinical embryology from Monash and brings in extensive experience to the table. Dr. Meeta Sharma is again an ASHRAE certified clinical embryologist with more than 20 years of experience. She also is a cluster head at Birla Fertility. And she comes with almost more than 10 years of experience in embryo biopsies. We are extremely happy to have Dr. Charu Chatterjee. Dr. Charu Lata is the scientific head and consultant embryologist at MedCity IVF. Again, Dr. Charu is well known to many of us here with more than 20 years of experience in embryology. These are all my panelists. I hope I haven't missed anyone. And let me start by sharing my slides. So I hope my slide is visible.
Yes,
Yes, it is visible.
Okay. So, with that brief introduction, the scope or the aim of this panel discussion is not actually to debate whether PGT is useful or no, but to look at how the biopsy per se and different aspects of embryo biopsy could impact the outcomes in PGT cycles. So, if we look at the PGT versions over years and how this procedure has progressed. We started off, so two major changes that have happened over the years is that the stage at which we do the biopsy and the different genetic platforms that have evolved over the years, which help us in diagnosing the genetic to make a genetic analysis more precise. So we started off with polar body biopsy and cleavage stage biopsy as the embryo stage at which we could do biopsy, and the genetic platforms were very limited, with fish having very limited number of probes looking at very limited number of chromosomes. Then we moved to version 2, where we said that the best stage at which we can do a biopsy is at the blastocyst stage, and we need to analyze all the chromosomes, and hence came in the concept of comprehensive chromosome screening and different platforms available. Today, the most commonly used is the NGS platforms. Following that came, all the controversies of whether we're doing it right, apart from, the biopsy per se. Is it really beneficial? Other terminologies, right? And then we started streamlining this. The PGT International Society came up with guidelines in the phase 3. The terminology changed from PGS to what we now know as PGTA for aneuploidy, PGT M for monogenic disorders, and PGT-SR for structural rearrangements. And also, at this point, a terminology called mosaic embryos was defined, and then started the debate about how this again limits the use of PGT. And then probably the version 4 would be going ahead, since PGT is highly invasive, can we look at non-invasive PGT or cell-free DNA analysis from the spent culture media. So this is how the procedure has evolved, and we are going to look at different aspects of it. So starting with the stage at which we do the embryo biopsy, and if I can ask my panelists, many of them would have been in an era where we were doing blastomere biopsy, but now have moved to blastocyst biopsy. So why did we actually stop doing this? And what were the limitations of doing a day 3 biopsy? Because when we debate and say that it is useful in advanced maternal age, a major limitation is that many of our embryos don't grow to blastocyst. Can we do a blastomere biopsy? And hence it is important for us to discuss what are the limitations of doing a biopsy at a cleavage stage or a blastomere biopsy. So anyone from our panelists could take up this question.
Can I take it?
So
Hello.
Please go ahead, Dr.
Yeah.
Charu.
So initially, even I have done day 3 biopsy when we have not NGS, but we have only FISH and PCR and the limited probe for 13, 18, 21 and sex-linked diseases. The only issue is whether we are taking here only one cell, probably the DNA is not enough to, tell every thing about the embryo, and the mosaicism is the another challenge what we have. Once we have blastocyst and we do the trophectoderm biopsy, the number of cells will be more precise and more accurate results we can take rather than day 3 biopsy.
Yes, so specificity of diagnosis is much better with blastocyst biopsy. Any other points to add to that? Dr. Priya, you want to add something to that?
We used to do only a single blastomere biopsy previously, but then of course the results were more questionable with that. So we started doing 2-cell biopsy with that. With that, obviously it was observed that the results were also going down. The implantation rate was low. And that was another reason why the PGT1 actually was discontinued at some point, because the results were poor, and our the pregnancy rates also fell with that.
Yes, very true. So we had a drop in our implantation. The outcomes were extremely pathetic with day 3 embryo biopsies. Any one of us doing blastomere biopsy in these days, in these times? None. So that's good. All of us have moved. So this is like this is more or less obsolete. Anyone wants to add to that?
I would like to add something in this. While we were doing, day 3 embryo biopsy, the chances of lysing cell also was there. If the technique was not, the biopsy was not done perfectly, then there were high chances that we may damage the cell which we are aspirating. Whereas in day 5 we there are chances where we may lyse some of the cells, but still we get good amount of sample which can give us accurate report or a more precise report, as Dr. Priya and Dr. Charu has said.
Yes, so we're having more number of cells here. Chances of lysis are less, because here in blastomere we're handling 1 or 2 cells, and that becomes an issue.
That's a very important point, that there are some cells left out of the 5 or 8. Some are left at least for analysis. That's a good point.
Yes. So very well said by everyone. And just to summarize, yes, studies do show that when we do a blastomere biopsy, because we're looking at a 8-cell embryo, removing 1 or 2 cells, we are drastically reducing the biomass. Second, yes, studies do show, and this is a very good study by Richard Scott and team, where they did a transfer with cleavage biopsied embryos along with another non-biopsied, and compared that with the similar group in blastocyst biopsy. And what did they see? A significant, close to 40% reduction in implantation if a biopsy was done on day 3. And this changed the entire version for us, and we moved on to blastocyst biopsy. Third, also, the average number of errors are found to be much higher at a cleavage stage, much lower at a blastocyst stage, whether it is self-correction or whatever the biology behind it. But then, yes, that is also another scenario. And then we have more cells for diagnosis, and hence we have a very strong diagnosis there genetically, and hence today all of us understand that it is only blastocyst biopsy that needs to be done, and no other stage of biopsy. So yes, a lot of evidence there with blastocyst biopsy and comprehensive chromosome screening being the right way and the way forward. So now we will focus on only blastocyst stage biopsy. Does selecting morphologically good blastocyst matter? And if I can have Dr. Mehta's opinion on this, or any of you panelists. So is it important that we select a good embryo for biopsy?
Sure. Basically, when we plan for embryo biopsy, the selection of the good blastocyst is the most important in terms of the ICM as well as in terms of trophectoderm and thinning of the zona. All three parts, even the expansion. So, correct selection of the embryo before performing the biopsy is most important, as it is not only how to biopsy, which technique you are using for the biopsy, but we are more interested in post-thaw survival of the biopsied embryo. That also is very, very important during the embryo transfer when we are planning for the transfer of the biopsied embryo. If the selection of the trophectoderm is very poor, then it may result in the poor thaw survival of the embryo. And obviously the selection, if the trophectoderm is very good, and it's better to, one may be unable to get good number of these cells, at least 6 to 7, 5 to 7, 8 cells can be easily aspirated from the trophectoderm. So obviously the selection of the good blastocyst before performing the biopsy is the most important.
Sure. And so Dr. Mehta spoke about having a good trophectoderm. Dr. Sujala, any other criteria that we use when we select?
Yes, even good ICM also, not only trophectoderm, ICM and thinning of zona and expansion is all four criteria are more important.
Yes, definitely. So, Dr. Sujala, you want to add to that when you select blastocyst, what are the parameters you would, so if you have
sometimes, ma'am, selection of cases is important, as Meeta ma'am told, but most of the time where we do PGT in advanced maternal age, we will not have a selection criteria. Means we will have a very few blastocysts, and if the patient insists or there is a history where we have to go ahead with PGT, we have to go ahead with the embryo available after proper counseling. So selection involves the patient also, the clinician also. It is a team selection in selected cases. In those cases, after proper counseling and telling the post survival and implantation drop also, we can go ahead with sometime BC blastocyst also, because many studies based on morphological correlation of PGT, we have seen still there is a 20% of C-grade blastocyst which can give a pregnancy. So the option should be available in selected cases. So where we don't have many number to select that which is the good one or which we cannot deselect.
Rightly said, Dr. Sujala. So in scenarios where obviously you will select the best blastocyst, you will prioritize them based on the level of expansion. So higher the expansion or greater the expansion, the better. And of course, the trophectoderm and inner cell mass. But in scenarios, as you mentioned rightly, where you have poor quality blastocysts or limited number, where you do not have much of a choice in advanced maternal age, for example, what are the limitations when we have to go ahead and do a biopsy of a poor quality blastocyst? Any one of the panelists?
May I take it?
Please, Dr. Suachala, please take it.
Well, in terms of technique, also there is a drawback. Let's talk about the technique as well, because the learning curve of performing biopsy on a blastocyst is much steeper than a blastomere. Of course, we all moved forward, but then the learning curve was steep. Now, the limitations of performing on a poor quality blastocyst are the technique also to begin with. So when you're trying to bring out loosely packed trophectoderm, there is a high risk of pulling out, no matter how much you waited for them to expand and took them to day 6. There is a high risk of pulling out the inner cell mass as well. That's a very big risk of performing on poor quality blastocysts. When it comes to technique, And then, of course, definitely when you perform a biopsy on these poor quality blastocysts, the result is also expected to be, aneuploidy or something that is not favorable or mosaic. The third thing is that when you vitrify such embryos and you thaw them, the survival also becomes a challenge. So, like Dr. Sujla said, proper counseling is extremely important. To begin with, we try to discourage biopsy on embryos that are going beyond C grade, because sometimes patients say no matter what, just do it. It doesn't make sense, because all these criteria then don't are not favorable to do biopsy. A, the technique; B, the report; C, the survival, vitrification and post thaw.
Very well said, Dr. Suvarchala. So it's also difficult to biopsy a poor quality blastocyst. Survival is questionable. But we have Dr. Deepak here, who's a geneticist. And Dr. Deepak, if you can elaborate, does morphology have any correlation to the aneuploidy status? And what
We
is your
believe for the longest time, we believed that bad morphology, definite aneuploidy and good morphology, low chance of aneuploidy. But unfortunately, that's not stand the test of time. We have excellent looking blastocysts with complete aneuploidy and extremely bad looking blastocysts, which are euploid. So I would say that as far as it's biopsyable, I would definitely put it for PGTA.
Yes.
I would not look at it by morphology and decide that, oh, this I should put it for PGTA and this not. As far as embryologist, you can biopsy it, just go ahead. Because we have seen, you all have experienced more than me, that extremely bad blastocysts that you just put it with the hope it'll implant has given you excellent results. And there have been instances where you're sure AA blastocyst and nothing happened. So I gave up on that idea after first few attempts of saying that no, let's judge the morphology first. I think let's not really look at it, because I think one of the, I would not say bad, but one of the not so great marker of selecting embryos is morphology. We all have sworn by it, we all have been trained by it, but we all know from our experience that it's not as linear as we have thought it to be.
Yes, so I think that is the beauty of this panel, that we have contributions and we have thought processes coming from the embryologists who are actually selecting the embryo for biopsy and who are actually doing the procedure. And we also have geneticists who have their opinion on, as long as you give us intact cells, it should be good. Right. So I think, as rightly put by the panel, there is no straightforward answer, though we select the best looking blastocysts for biopsy. And this is a good study by Capalbo and group, where they have looked at the availability of cells for analysis based on the embryo grade and the outcome. And clearly they suggest that blastocyst morphology does not affect the results. Poor quality blastocysts, if they are found to be euploid, they retain their implantation potentials. Also, as long as you get good number of cells, we believe that you will have a good diagnosis. But the study says that in 95% of the patients, even if you have less than 3 cells, you could end up having a good diagnosis. And this is one school of thought which mentions that, consider all the blastocysts for biopsy, regardless of the morphology, as long as they are expanded. So the emphasis here is not on the quality of trophectoderm or inner cell mass, but on the expansion stage. Also, this is a review which looked at multiple factors which influence the implantation of euploid blastocysts. And what does it suggest? Blastocyst morphology, there is fair evidence to suggest that an increasing morphology grade of ICM trophectoderm has a positive impact on implantation potential of euploid embryos, as long as it's found to be euploid. And blastocyst expansion is important. So fair amount of evidence that not fully hatched. So preference to expanded blastocyst over hatched blastocyst. So now let's focus on the technique of biopsy. Let's start with assisted hatching. We do know that for the blastocyst biopsy, you could choose to do an assisted hatching either on day 3 or at the stage of the blastocyst. So any of the panelists can take up this question. Both the methods, what are the challenges if you have to look at doing a assisted hatching on day 3 or day 5? And do the outcomes really vary based on which day you did the assisted hatching on a blastocyst?
Can I start?
Please go ahead, Priya.
I've never done a day 3 AH there for a biopsy. I've always done it only on the day of the biopsy, hoping that there will be, I think it's more convenient for me as well that I see where the trophectoderm is, and then I put the laser wherever it's necessary. That's number one. I don't have the ICM herniating through the laser I've already done on day 3, and so I'm left with the an unique situation. Another thing is on day 5 or day 6, I hope that when I see the blasters, it started little bit hatching out, so I can pluck out whatever is there little bit and then give it to Deepak for analysis. So I hope that I always prefer to do only on the day of biopsy, and hoping that I don't have the unique situation. And two, most of the time, by the time we see in the morning and the evening, they start hatching out slight, and that gives us an advantage of taking out the trophectoderm in that way. So I feel that biopsy on the day of, laser on the day of biopsy has been very beneficial to me. So I go ahead and do only that.
So Priya, if I understand, you would do an assisted hatching in the morning once you see it as a blastocyst, and then later you would wait for it to herniate and then do a biopsy, or would you do it sequentially?
No. I just do simultaneously the assisted hatching and then do the biopsy. I don't do any assisted hatching at all.
So that is a good idea, Dr. Priya. But my learning it came at a price. So I used to do day 3 hatching, take it to day 5, and be shocked with the inner cell mass coming out.
Exactly.
And then wonder which way to go in and all that.
Exactly.
But just 2-3 cases later, I decided I'm never going to do day 3. So I do blastocyst stage hatching and immediately take out the
Exactly. We have the
it's
laser
much
at
more
our hand.
convenient than this tension of having to
What
tackle
is
with
going
the
to come
inner
out
cell
of that trough we have made?
Yes,
definitely. One of the biggest drawback is that you don't know what is
where the ICM will.
the MPO is going to
exactly.
Absolutely. It is very convenient because day 3 you can see between the cells, and it's very convenient to put a shot there, but then it's not good on day 5.
No. I think just go ahead, do the laser, do the assisted hatching, and wherever you want it, like where you've decided to do the biopsy, and then do the biopsy. By God's grace, if it's already started herniating a little bit, your life is so much more better.
Of course.
So I think few of us started off that way, right? We were hatching it earlier, waiting.
Earlier in the morning, because that time we were confident that herniate cells, we will not damage the blastocyst. So I used to do laser in the morning, wait for the herniation, and then, but now with the experience and practice with good expanded blastocyst, we do hatching at a time as well as biopsy at a time.
Exactly.
And just out of curiosity, all those scenarios where the inner cell mass was herniating, where you have done assisted hatching on day 3, Dr. Meeta, Dr. Sujala, or Dr. Ram, any one of you all, if you all have traveled that journey, how did you manage to handle that situation where you have done a day 3 assisted hatching, and on day 5 you see that the inner cell mass is hatching out? How did you proceed with the biopsy, or any of the panelists can take
Go the other way and make your life miserable. That's the only way. Avoid the inner cell mass, go the other way. You deserved it.
So I personally, in my experience, I have not done hatching on day 3, but yes, late day 4 hatching I have done in some cases. That when we could see late day 4 that we could locate the ICM part, then we could give shot to the other part, so that in morning, if I have to travel somewhere, so that in late night, maybe in morning I can get good cells to biopsy, and then I can fly. That was like I have done twice at some of the remote center. And second thing which I have encountered is, like embryo without giving shots on day 3. On day 5, we saw the embryo was almost half hatched out because of the premature hatching, and the embryo was hatching from ICM part. So ultimately, we had to do another shot on another side and then aspirate from the another side. But at the same time, we made sure that we, completely, we tried to put that complete embryo into the zona, so that at the time of at the time of freezing and thawing, we should not damage the embryo with our
Sure.
micropipette, or maybe there are less chances of splitting embryo and all.
Sure. Dr. Sujala, you want to add to that?
Ma'am, I have never done day 3
Okay.
assisted hatching. It is a sequential. So I'm just listening to your experience.
Okay. So I think in the times what I used to do in those times when we were doing day 3 hatching, if you see the inner cell mass herniating, all you do is completely make it a hatched blastocyst.
Okay.
Now the blastocyst from the zona and then biopsy it as a hatched blastocyst from the other end. So I think that was how we found our way of dealing with those difficult scenarios. So like rightly put by all of y'all, if we do a hatching on day 3, before complete, early hatching can happen, inner cell mass may herniate. Most importantly, I think you will see embryos in different stages of herniation when you sit to do a biopsy, and then you are in a fix. You end up doing biopsy multiple times the same day. If you do a assisted hatching on the morning of day 5 when it is a blastocyst and wait for herniation to happen to do the biopsy, then again there is repeated exposure. And as all of y'all have said, the best way is with reduced exposure is the simultaneous zona opening and trophectoderm biopsy. But I think Dr. Suvarchila rightly said it. It needs a high level of skill. The complexity of skill is moderate to high level if you're going by that method. But that's the best. So we all did mention laser-assisted hatching on day 3 increases the stress, risk of inner cell herniation, premature hatching. Also, I think there could be some altered exchange of media because you're keeping it open zona in the culture media. Also, blastomere loss is always a possibility if the zona, if your the zona that you've drilled is larger in diameter. So these were all the side effects of doing it there. Also, now if we have to compare the outcomes, and this is interesting, and this study looked at a huge amount of 7,300 biopsies. They compared the day 3 pre-hatching protocol versus the simultaneous hatching and biopsy protocol. And if you look at it, the survival, clinical pregnancy, ongoing pregnancy, and live birth rate was significantly better if you do the assisted hatching and biopsy in one sitting and simultaneously. So now moving on to the methods of trophectoderm biopsy, you know that there is a laser method where you pull the cells and just laserize all of them and you have biopsied them. And the next is the flicking method, where mechanically you would flick the cells by brushing it against the holding needle. So does it matter the method of biopsy, either flicking or pulling method, and what are your personal choices? Why do you prefer a particular method over the other? And if I can have all of our panelists contribute to this question, what is your personal favorite?
I mean, it depends on embryo. Usually the method is selected. There is no particular like this will do. Based on the embryo, how it is, laser and sometimes combination also. Laser plus flicking.
Okay, so you don't have a fixed method with which you're comfortable. Fair enough.
Yes.
Everyone is fixed on, I only do this method and I'm only comfortable with either of that. Or all of us use the combination based on how the embryo grade is and the time of biopsy, how we are able to hold the trophectoderm cells, the challenges at that point. Do we decide?
I think when we hold, I mean, we all use a little bit of laser, like, just to at the end, we all just use that. But then whether we are using complete laser or we are doing the flicking method is, I think, is where the difference lies. I think I personally decide on it when I start pulling on the trophectoderm. And if it comes decently, then I think I would always prefer the flicking method, which I remember saying that, I mean, from the publications, that it gives better results in terms of genetic analysis. So the flicking method is slightly more preferred than the complete laser to pull off all the trophectoderm, because we can lyse the cells as we do entire laser to separate the specimen cells from the embryo.
If we can have Deepak add to Deepak, does it matter your genetic analysis? Is it different based on the method that embryologist uses to biopsy the embryo?
So I don't clearly remember any papers which did compare very clearly the outcomes between a pulling method versus a flicking method. I think there is just that innate belief that, okay, my laser is going to be a little more damaging and therefore I would get these results, but not that I recollect any clean studies demonstrating a significant difference between the two methods.
Okay, great. And if we're using laser, if I may just know from all the panelists, how many laser shots? Is there a limitation to how many laser shots you would use? Or we all know, like Deepak said, we all believe, right? There's laser, it's heat.
It lyses our cells. So
Yeah.
yeah.
Too much.
Kind of use it very conservatively.
Yeah, the lesser the better. We would like to have one at the top and the one at the
Yes.
bottom.
Yes.
And see if we can just flick it and take
Pull
the
it
cells
and
out
flick
as
it
much
and
as possible.
Right. Any thumb rule, not more than 3 shots, not more than 4 shots?
Not more than 4 shots.
Fair enough.
Not more than.
I think definitely not more than 4 shots.
Yeah.
And I think combination is always better for
Absolutely.
comfort of embryologist as well.
Fair enough. So rightly put by all of you all, and this is a small study which looks at 280 patients and maybe 1,000 trophectoderm biopsies, and it is trying to compare both the methods. So laser exposure obviously is highest in the pulling method, where you cut the cells with the laser. However, there is no impact on the implantation rate. So both the methods of pulling means the laser method and flicking is the mechanical method. Another parameter which the study looked at is the collapse. We all know that as soon as we biopsy, the embryo collapses and then re-expands. And we all believe that this is one of the parameters that we look at to see if the embryo has remained viable post-biopsy. And the study also looked at that. What did it conclude? With the flicking method, there is a stronger contraction immediately post-biopsy, because obviously it is very aggressive and you would have realized that embryo immediately collapses as compared to the laser method. However, the rate of expansion, both the methods is the same. It does not, and again, it does not impact implantation. So they concluded that irrespective of whichever method you use to do biopsy, whether it's the laser or the mechanical method, none of the outcomes in terms of survival, implantation, miscarriage, or ongoing pregnancy rates are significantly different. So, I mean, we can choose whichever method we're comfortable with. Now, coming to the number of cells, Deepak, if you can take this, do the number of cells that you receive for genetic analysis, do they really impact the genetic diagnosis?
Yeah, as a geneticist, even if you give the whole human, we will say it's inadequate. We need more DNA. So we are one of those most cell-hungry people. And most often we have this habit of saying DNA less, DNA less. I think we are cribbers in some extent. Yes, but with the ability to do better and better amplifications, this lower limit or upper limit kind of debate has really settled down. As far as you're giving something that is visible under your pipette and you say that, okay, there are 3 to 5 cells, a geneticist is good enough. This was all a debate when we all had very limited tools of amplifying good DNA. But you must also remember that as tools have become more and more sensitive, the ability to even amplify junk has become more. So here I would not
Yes.
worry about limited DNA rather, but how much of extrinsic DNA contamination is coming in is a challenge. When we all debate about these mosaic embryos coming in, a good section is that the extrinsic DNA has become more over the embryonic DNA. So it's about the relative balance between the two. So I wouldn't have a number that, okay, 3 is better over 2 or 3 is less better over 5. I don't think there is a linear relationship. It's more of a ratio of actual embryonic DNA versus extrinsic contamination.
So that was an excellent point that you highlighted, Deepak, which we as embryologists should know, because we always believe I need to give a good chunk because I'm scared of a no diagnosis, right? The biggest fear an embryologist has, probably it's less of no pregnancy, but more of no diagnosis. And like you said, yes, we have better platforms. They're highly sensitive platforms today, and we should not fear that, if I give less number of cells, the diagnosis could be hampered, but we should be more concerned about the contamination. The other side is embryologists. We also believe that whilst we want to give a good biopsy, a good number of cells for a good diagnosis, is it going to impact the outcomes, my implantation? So anyone from the panel would like to take this, the number of cells or a larger biopsy versus implantation? Does it reduce implantation of those embryos? Dr.
I would definitely feel that the more the trophectoderm I'm going to take away from the embryo, the lesser the implantation could be. So now that Deepak has said only 3 cells are enough, then we will give the least amount possible and they can give us the diagnosis.
Yeah, I stand corrected. It is a ratio of the extrinsic versus the embryonic DNA. So more the embryonic DNA, the better. I started by saying, even if you give me the whole human, I'll say it's inadequate DNA. So that
we would like to
doesn't
keep
stand
it to around 5
Absolutely.
to 8 as
something
much as
that's
possible. We
comfortable.
don't want to take, because we might say about the pregnancy outcomes, we also don't know about the epigenetic outcomes. There are a lot of things that we are looking at. So we should be as conservative as possible in that. Maybe, that's my strong belief.
Very true. I think rightly put by both of you all. So this is a very interesting study which looked at the number of cells and its impact on one no diagnosis, because that is our biggest fear, versus implantation. And what it stated that the diagnostic efficacy increases if you have, more than 5 cells. It is maximum beyond 6 cells, if you can see in the diagram there in the graph. When you have 8 and more cells, literally the chances of no diagnosis doesn't exist. However, if you look at the implantation part of these embryos, and again, they have categorized it based on the embryo grade, the trophectoderm grade, number of cells biopsied versus implantation. And what clearly it suggests is that the implantation potential is negatively impacted by the number of cells you biopsy. The higher number of cells you biopsy, you would be reducing the implantation potential of that embryo. And this is more so if the trophectoderm morphology is poor. So this is something we need to keep in mind. Another study which again looked at the same, suggested the same, that higher the number of cells you biopsy, probably you will be reducing the implantation potential of the embryo, and hence also reduced birth rate. And hence it's important that we give an appropriate size of biopsy. 4 to 5 cells would be adequate without compromising on the implantation potential. Now coming to few of the last questions, genetic testing. And we know that the genetic platforms have evolved. They have become more sensitive, as rightly put by Deepak. This question is for you, Deepak. During the technical validation of these platforms, is it important that there is an evaluation of concordance between reanalysis results in embryos where there was also an available initial testing result? So you have an initial result and then you rebiopsy and look at the concordance of that. Is this important for technical validation of platforms?
Absolutely. So at the technical validation of platforms, we talk it at two levels. One is technical replicates, one is biological replicates. So when I mean a technical replicate is you're given the biopsy once, I've split it into two at the level of DNA and done my genetic analysis twice. And this is called as a technical replicate where absolute concordance is very, very essential. So whenever you're choosing a genetic lab, the first question you will ask is, show me your results of your technical replicates. See, it's the same DNA coming twice. And if there's a different result, then you know there's something wrong with the platform. Now, the reanalysis results with second biopsy is often challenging to interpret. Is because we also know that biopsies taken from different regions of the embryo yields different results, because we also know that a lot of blastocysts, especially at the level of trophectoderm, are mosaic. You may have biopsied cells which are euploid to begin with, but the second biopsy has come from a region which is aneuploid. So at the level of testing of the genetic platform, I would be a little wary of using two biopsy results concordancy as to say that, okay, the platform was good or bad. Technical replicates is the gold standard.
Okay. Great. Thanks for that, Deepak. And as rightly pointed out, this is another review that looked at different publications where rebiopsy was done and a comparison. And they've used, of course, reference sample has been evaluated in different platforms, SNP, Array, CGH, Array, CGH, and so on, and NGS, and so on and so forth. And close to, I think, 1,900, 2,000 biopsies. And what did the review suggest? That if the primary diagnosis was euploid, then a re-diagnosis, the chances of having a euploid diagnosis again is very high. It's good, almost 94%. Now, if the initial diagnosis was aneuploid, then the chances, then the rebiopsy, the same diagnosis, getting a aneuploid diagnosis is around 80%. So looks like the concordance is reducing. However, the interesting part is when you have the initial diagnosis as mosaic, a repeat diagnosis of a mosaic was seen only in 43% of these embryos. And like rightly pointed out by Deepak, I think this is important for us to know that the concordance level may vary between initial and a rebiopsy based on what was the initial diagnosis. So now going to the next question, Deepak, again for you today, we hear a lot of, we know mosaic embryos giving live births. We also now hearing about segmental aneuploidies also resulting into live birth. So the basic question is, is something happening in the genetic lab that we don't understand? Do detection of both segmental aneuploidies and mosaic vary between platforms?
Just before I answer this question, I'll just like to go to the previous point, where your concordancy between two mosaics is problematic. So the good news is if your euploid is euploid, aneuploid is aneuploid, you don't really need to rebiopsy. If it's full aneuploid diagnosis and you have good experience with your genetic lab, I wouldn't worry about redoing it. No magic is going to happen between two biopsies. Your challenges with mosaic embryos and with mosaic, the complexity is a nightmare for the genetic lab. It's a nightmare for the embryology lab. So rather than, doing a rebiopsy with something better will happen, and if the result is different, you're still not sure whether the first result to believe or the second result to believe. So don't get into that mess is my simple advice. Because it's just going to add on to your time, your cost, the patient's cost, the geneticist's cost, everybody's time. And essentially, we have seen that it doesn't really yield anything significantly different.
Sure.
So my simple advice would be, don't worry about rebiopsying unless there's a no result and you really want to aneuploid the result out from that embryo. So between no and yes, do it, but not because no magic is going to happen. You will probably rescue 1 in 100 embryos, which is not really something going to matter unless this is one little embryo for the patient. Now, talking of segmental aneuploidies and mosaicism varies between platforms. Mosaicism definitely not just varies between platforms, but varies across genetic labs as well. You would have experienced yourself, and we had a discussion, Varsha, also, that there some labs do have a tendency of giving different reports. Now, the problem perhaps is not largely at the level at which the way the sequencings are done, but rather the level at which the sequencing results are interpreted. So as a geneticist, I apply a certain cutoff that, okay, there's some amount which we will call it as noise, some amount which we'll call it as signals. So the cutoff, I may keep a very low cutoff that I want to get everything that's even remotely looking genetically abnormal, I would want to report. And as a consequence, we will end up having more mosaic reports from a lab. So it's a cutoff filters applied by the genetic lab. Segmental aneuploidies definitely is more platform driven, the way the sequencings are being done there. So between mosaicism and segmental aneuploidies, yes, there is significant contribution of the genetic lab and the platforms used.
Sure, sure. So I think, yes, rightly said by Deepak, and this is again, I quote another paper from Nathan Treff and group, where they do mention that, yes, the detection limits are different, and hence it would matter in cases of segmental aneuploidies. So on that note, Deepak, I think all of us on this panel and in our audience, most of us send our biopsies to a third partner, a genetic lab who does it for us. So what are your tips to us? How do we choose the right genetic partner? Are there any specific parameters we need to ask them while choosing who we send our biopsies to? Or is it that we just send a few biopsies to them and see what is their mosaic rate, what is their no diagnosis, do I get pregnancies? How do we go about this?
Yeah, so this is a very complex and difficult to, kind of give a very clear-cut guideline on it. But first, I would say it, rather than looking at anything of the lab, you would want to have a partner who has a good services to pick and drop your samples. Because when you're working in an area where your genetic partner doesn't have a service provider who's going to pick up and drop your samples, or going to take 2 weeks to pick up your samples, you wouldn't want to go to that. So I would rather look at, the proximity of the genetic lab. And the first thing is what I would say is how good or bad are the pickup drop services, number one. Number two, definitely it would be ideal to send off a few trial biopsies to see that are your results. I mean, no result data is more worrying. That what is your diagnosis failure rate? You wouldn't want it to be very high. I mean, we did have a discussion that how will we evaluate an embryologist also? Your no diagnosis or failure rate should be the lowest. So because there are enough centers now today in the country offering this diagnosis, most of these centers have a baseline data. So you could, if you're choosing a new lab, ask them for baseline data. What is your experience with doing a PGTA earlier? How many centers you have done? How many biopsies you have done? Give us your validation data. And they are obliged to give you, they should not tell you no. If they're not willing to give you, you better don't do it. I'm making many enemies with the genetic labs now because I'm making these statements on a public platform, but I'll be very vocal about it. That as a service provider, they are expected to give you this data, that what was the failure rate, how many actual biopsies did they do, we evaluated, what was the test failure rate, what was the aneuploidy rate, what was the euploidy rate, and more importantly, what was the mosaicism rates. I mean, there is no ballpark number, but a mosaicism rate less than 5% is, I would say, a qualifier of the lab, that I would say. Less than 5% overall. Now, I mean, they will also say that, some centers give me more mosaic rates and some centers don't give me. See, when I talk on panels from the genetic side, they often say that, we have had experience that some center embryos are more mosaicism rates. So then I tell them, you go and ask, because there could be an embryologist who is doing something wrong, and please report back to them. So don't go by a word of mouth. I would say ask for actual data.
Right. So I think that's a good takeaway point for us, Deepak. One is how is the sample transported? What is the turnaround time? Understand that process. Second is ask for their own in-house data about no diagnosis, mosaic rate, the number of biopsies they have evaluated, and how so that would be definitely helpful. now that we were discussing about the mosaic embryos, Deepak, this has always been a pertinent question. And this is what we are told. This is the definition, right? There is a threshold concept where we say less than 20% of aneuploid cells in an embryo biopsy, it is still a euploid. 20 to 80% aneuploid cells, and it is a mosaic, and more than 80 would be aneuploid. So I want to ask you a simple question. Is there a biological evidence to these cutoffs and thresholds?
Absolutely no. There is no data which has shown that, okay, 20% gave more live births. We have had evidences where even 80% or, complete aneuploidies have given euploid live births. There are enough publications around that. These are all mathematical calculations which have been done to say that it's more of a likelihood. A probabilistic model have been applied here, that the probability of a failed implantation or a failed pregnancy is higher because there are more number of aneuploid cells. That's it. There's no biological basis to these cutoffs. There are no studies done where they said, okay, we implanted 50% mosaic and did not land in pregnancy, because obviously these are not ethically correct to do studies. So at this point, we'll have to just rely on these numbers. I would say rather use your acumen and do patient counseling. I mean, I think rather than worrying about these numbers, so there are defined criteria coming out from different societies which are being regularly updated. Your genetic lab has to, so this is one more point, how well your genetic lab is updated with these guideline implementations. When they're reporting transfer or no transfer based on mosaicism, have they used latest guidelines? Because they're getting better and better with experience over time. But I would rather say that it's best is to counsel your patients that, okay, if there is a mosaic embryo, treat it like a no test done, and let's do a ina mina mina mo, rather than going by, ye thoda better hai versus ye thoda kam hai. Pregnancy is not thoda pregnancy and zyada pregnancy. It is a yes or no condition. So when the decision is binary, I don't think these gradients matter so much.
Sure. And then coming to the most important, I think all of us keep asking this, and you are the best person to answer that. And now thousands of reports suggesting that, mosaic embryos leading to healthy live births. And this was the paper that changed everything for us by Fiorentino, where, there were healthy live births from so-called mosaic embryos. So Deepak, what is your advice? Clinically, how do we handle? If I only have a mosaic embryo, how should we be handling those scenarios?
This is the most often asked question.
Yes.
Then most often is that, okay, I have 7 embryos, 1 euploid, I've done a transfer, what should I do with the rest? And given this data, and since then a lot of publications have come where individuals have reported healthy live births with mosaic embryos. So as I said, that when it comes to mosaic, there are defined criteria again, that 80% of chromosome 21, chromosome 18, which are known to give live births, it is like a strict no transfer. Your genetic lab would give you a guideline to transfer it, but when, even they will depend on what ACMG says. Ultimately, it's a discussion between you and the patient, that if the patient is wanting to take a risk, go ahead. What we have understood from RCTs or other, retrospective data of transferring euploid versus mosaic embryos, the live birth rate of a mosaic embryo transfer is similar to that done by morphology. So that goes to say that it is as good as not done a PGTA.
Right.
So if you take women about 35, a big cohort, you have had transfers with morphology. Let's say you get 30% pregnancy rate. With PGTA done and you only transferred euploids, you get, let us say, 50% pregnancy rate. You would get around 30-35 only with euploid embryos. So basically, philosophy is saying that you will get live births, but your chance of success is going to be low. So the very philosophy that you applied the PGTA to do live birth is getting lost when you're transferring mosaic embryo. So your patient should be aware that we are transferring, number one, your chance of pregnancy could be lower than that of the euploid. And number two, a good recommendation would be the patient should be subjected to, the baby should be subjected to prenatal diagnosis, just in case the patient is very anxious.
Right. Because practically, we only prefer once we see a report of low mosaic and there is no other euploid embryo, we say, okay, it's a low mosaic and hence you can take the transfer. But apart from that, any other takeaway points for mosaic embryos?
Not really. I mean, very complicated mosaicisms or all that you wouldn't want to, like, too many translocations seen, like we can see in some of them. We can see that, simple mosaics like one gain loss or one gain or one loss, they've resulted in pregnancies. But if you see at number 7, 8, 9, 11, 18, they've resulted in no pregnancy. So when there are more complex alterations, we know the genome is very unstable of the embryo and therefore not likely to proceed. But if there is one single chromosomal alteration, which is, kind of multiple duplicate, I mean, one duplication or one segmental loss or, kind of not very chaotic DNA, then you are more likely to get a pregnancy, is what the current understanding is.
Sure. So coming to no diagnosis or inconclusive diagnosis, Dr. Mehta, would you like to take this? What could be the probable reasons as embryologists? Are there something that we've not done right during the entire process of biopsy, or what is it? What could be the probable reasons for no diagnosis, apart from, of course, the embryologist not being very skilled?
Maybe it is the error may happen at multiple, say at multiple time sites. The error may happen. It may be the basically the cells aspirated are too less in number, or there may be error in the tubing. And it may be artifact or the noise during the when biopsy is performed, or maybe during transportation of the sample, or maybe at the level of genetic lab. So at the multiple steps, error may happen, which result in inconclusive or no diagnosis.
Rightly said,
Except
Dr. Mehta.
Yes.
Sure. Yes. So I think the prevalence of no diagnosis is around, 0.8 to maybe 4%. So less than that. And different causes could be also a poor quality blastocyst, where technically it's difficult to biopsy and get a decent number of cells, or the cells that you get could go through lysis. Also important are the shipping conditions, the transportation. From the genetic lab, I think it could be amplification failure. So these could be multiple reasons for no diagnosis.
Varsha,
Now,
just a point. Dr.
Yes.
Mehta was very diplomatic and modest. What happens first is a fight between all the three parties. The genetic lab will say, embryologist did not give me the good cells. Embryologist, I biopsied it. The clinician will say, you have not tubed it well. All of this will happen. My sincere advice here is that please accept it. I think 3.8% in today's context is not acceptable.
Right.
So as I said, first ask your genetic lab. As far as it's below 1% of no diagnosis rate, your genetic lab is good. Let us accept it that about 1% of total embryos will fail, and let's not get to the blame game.
Sure.
It will be that one unfortunate patient out of 100 who will have these issues. So my sincere advice would be that, don't break your teams, because this is bound to happen and we don't understand why it happens. Because there are multiple layers, multiple parties, multiple involvements.
Right. So as long as it's less than 1%, don't worry. But if it's exceeding that, then yes, we need to look into multiple factors.
So here is where the KPIs come into picture, that if your PGTA KPIs say inconclusive rates in your center is less than 1%, you have nobody to blame. But if it is crossing after a point, there's a matter to start worrying, and then investigations can begin.
Yes. So now coming to another important question is biopsy of a fresh embryo or a frozen embryo and rebiopsy. Any thoughts from?
Hello, Dr. Varsha ma'am.
Yes, please go ahead.
Yeah. So I have one question. So we had a case of a patient with the age of 37 and we had two embryos with the good grades. So I observed that we went for a biopsy where the result came as complex mosaic, and another one is this one aneuploidy. Why? Because while doing biopsy, there was a collapse in aspirating the cells. So I have this doubt: does the collapse of the embryo will really affect the results from the lab?
So technically, I can think about the biopsy. See, most of the times, I think at least 30-40% of the times, if it's a fully expanded blastocyst, it does seem to collapse, right? When you're just about to do the biopsy, it becomes technically difficult, but are you going to have a high mosaic rate because you biopsied a collapsed blastocyst? I wouldn't agree to that. Second, are you going to get less number of cells because it's a collapsed blastocyst? I don't think that happens, because you still pull the embryo, the trophectoderm cells into your biopsy pipette, and you look at the chunk, right? You have a gross idea as to how big a chunk of those cells it should be. So as long as you've had adequate number of cells in your pipette, I don't think the embryo collapsing should be leading to embryo having complex abnormalities. I wouldn't think so, but it may make your biopsy slightly tricky.
And also, I think mosaicism may increase if while doing aspiration of those, collapsed blastocysts, and if there's extensive, you have to pull them harshly, or if there is a high chances of lysis during the aspiration, that may, lead to higher mosaicism. That could be one of the reason.
No, I don't, I would not quite agree, because the lysis should not be causing a high incidence of mosaicism, right?
No, because if the
Understand,
embryo is
have a no
completely
diagnosis.
collapsed, and if you're trying to aspirate cells out of it, and if you're giving extensive, more laser shots, then are chances of inducing mosaicism to those particular cells.
Could be cellular debris, ma'am. If after collapse, if there was a cellular debris in which is the extrusion of the abnormal aneuploid cells. So during biopsy, if we are aspirating along with the TE cells, we are aspirating more of those cellular debris that might lead to complex mosaicism.
Right. So
Also,
maybe
I'll remind
Actually,
everyone.
instead of cellular debris, if extruded cells are extracted along with it, may result. I just don't know. It's just a
but
thought.
I think deliberately none of us would do that, right? None of us would aspirate the extruded cells, nor would we aspirate the debris, because we are very clear we want to aspirate the trophectoderm cells, which are a part of the embryo, and not anything that is extruded. So I think as long as we maintain that,
Yes.
yeah,
But
while doing the biopsy, I
even
think we should be good.
I differ with Ram, because if it results in lysis of the cell, then there are chances of no diagnosis rather than mosaicism.
Yes, sure. So thank you, Ram, for those inputs. Moving on to, biopsy, rebiopsy, biopsy of fresh, frozen. So any one of you have any take on those? Does it impact the survival? Does it impact the implantation? What does the data say? Because I think many of us do frozen biopsies. So it's a frozen embryo, we biopsy them, especially when there is a freelancer who goes to biopsy those embryos. He's not available throughout the month, but few centers who have an in-house embryologist for biopsy, they do a fresh biopsy. So does it really matter?
In terms of rebiopsy, if we are talking, I think, are we talking about rebiopsy also here? Yeah.
Fresh versus frozen embryo biopsy, and then we can come to rebiopsy.
Okay, I mean, oh, sorry, I do fresh because we are here all the time.
Right.
That is number one. Number two, but then if there are embryos which have to be, I mean, on a later day when patients decide that they want to have it biopsied, also we have done. But I think biopsy and refreezing has got lesser effect on the embryos than a rebiopsy. Rebiopsy, I think I'm not a great fan of it. I think it is also has not shown great results, but having multiple biopsy is not great. But I think on a frozen embryo to take it and biopsy it and then refreeze it has got lesser effects than rebiopsy.
Right. So I think rightly put by Priya. The thaw survival rates. So this is a study, though the numbers are quite low. So group 1 is all the fresh biopsies, group 2 are the frozen biopsies, and group 3 are the rebiopsies, which would have undergone 2 freezings and warmings. Though the numbers are quite low, what the study suggests is yes, the thaw survivals with once biopsied and vitrified warm embryos are significantly higher than twice biopsied and vitrified warm embryos. Also, a slight reduction in the clinical pregnancy rate with additional vitrification warming, and a large reduction with an additional embryo biopsy. So, rebiopsy does seem to be impacting, but neither of this were statistically significant. However, the combined effect of both an additional biopsy and vitrification warming significantly reduced the clinical pregnancy rate. This just goes to say that we need to be cautious in cases of should not be too adventurous and put the embryo through multiple rounds of vitrification and biopsy. So let me quickly move to one of the last questions, the safety of embryo biopsy in terms of perinatal and maternal complications specific to that. So any thoughts about it? How safe is embryo biopsy as far as the perinatal outcomes are concerned, and also about the maternal complications? Are there any maternal complications during pregnancy in PGT pregnancies? So any
In
thoughts on that?
early days, I used to keep contact with the person who has done that time PGD and PGS. We used to say that till the child is born or 2 or 3 years, few data I have collected, but in my short data, I haven't find any abnormality into the baby. So then, because patients come from the periphery and we are losing the touch till the delivery or the child is born, we have stopped taking that. But initially I have done the study, and that few number of study, I didn't find any abnormal kind of in the child.
Right, rightly put, Charu. So this, I think now there are multiple studies which have looked at the impact of embryo biopsy on both obstetric and perinatal outcomes in frozen thawed embryo transfer cycles. Clearly, the studies suggest that as far as the perinatal outcomes are concerned, there is no need to worry. However, the obstetric outcomes, the incidence of hypertensive diseases during pregnancy or hypertensive disorders during pregnancy are significantly higher in PGT pregnancies. And again, another report which suggested the same. So I think a word of caution here, and this reason.
Can I also say that I'm not sure if it's because of PGT, because the same has been attributed just for blastocyst transfers. A blastocyst transfer by itself has got a higher chance of preterm and PIH in mothers. So I'm not sure, because we are doing biopsies on blastocyst only now. So eventually we are transferring blastocyst. It's more probably attributed to a blastocyst transfer rather than to a PGT, because we are doing only day 5 biopsies.
Okay, so Priya, there is this study actually compares the pregnancies, blastocyst transfers, PGT versus non-PGT.
So probably we have a higher chance in this than the regular blastocyst transfers also, which is quite scary.
Yes, and in fact, it's a 3-fold increase in the odds of eclampsia. And the reasons could be, see, all these are frozen transfers. There is no corpus luteum. So, there is, it deprives the patient of vasoactive
and
hormones.
also at higher advanced maternal age, those things also put together.
Already are prone to have high risk of all these issues. Also, whether the biopsy, the trophectoderm biopsy, may be affecting placentation,
Yes.
causing an imbalance between the pro and the anti-angiogenic factors is something we don't know, but just a word of caution there on this. And yes, let me conclude on everybody's thoughts on is it PGT, is it beneficial? And if each one of y'all can have your own thought to that, because we know it is still controversial, PGTA, but if you look at the use of PGTA, significantly very high in US, almost 20% cycles are PGTA. UK and Europe, we know they're conservative, 2 to 3%. But all of y'all have been doing PGTA in your practice. And what is your take on it? Is it really beneficial to our patients?
In certain patients, yes, I think USA is an overkill. They are absolutely, it's an overkill on everybody doing PGTA. I'm not sure if it actually has any benefit. It is like doing, anybody goes through an IVF, they come around the entire belt and then comes out of the PGTA also. But I think if we are doing it on certain set of patients that has been shown to have some indication, I think it does help our patients at least make a decision on whether to go ahead and have the embryo transfer or not. And definitely this has decreased the miscarriage rate. So in patients who have RPL, it's absolutely is indicated and has benefited our patients in them, and in patients in advanced mental age, it has helped us. But I'm definitely sure it's not for everyone.
Sure, great.
Sorry to disturb, ma'am. We are running short of time, so requesting you to.
Yes, sure. So each one of you in one line, do you believe this helps the patients to achieve a higher live birth rate?
It is customized, Dr. Varsha. Absolutely agree with what Dr. Priya has summarized it as.
Yeah, for selected cases.
Sure.
Yes.
Sure.
And it does also help to, reduce the time to pregnancy in some cases.
And help us to single embryo transfer.
Transfers, yes.
Right, reduce the abortion rate probably
Yes.
in advanced maternal age.
So I
Thank
think
you.
there was a
Thank-
systematic review done. I think we had also done a part of it. And it's very clear that women with advanced maternal age, recurrent pregnancy losses, recurrent implantation failures, and severe male factor infertility.
That was
These are
the
four categories.
Exactly.
yeah,
where there is a
indication about our ART Act also.
Yeah,
So we
yeah.
cannot
Beyond
do
is
PGTA
these
for all.
all is out. But yes, for these four conditions, I think there's clear evidence and we should apply it.
Sure. Thank you so much, all the panelists. It's been a wonderful panel. All of you all have given your years of experience and your inputs into this session. Thank you so much for making it very interactive, very informative for all of us. Thank you once again, Dr.
Thank
Kalpana.
you, Dr. Varsha, for having us.
Thank you, Varsha. Thank you, Kalpana ma'am, for the
Thank you very
opportunity.
much, Dr. Kalpana ma'am.
Thank you, everyone, and have a good evening.
Over to you, Dr.
For
Kalpana.
putting me here.
Thank you, Dr. Varsha. Thank you, Dr. Kalpana.
Thanks.
Yeah, it was a wonderful discussion, Dr. Varsha. You have initiated, and now the clinician can understand embryologist difficulty, I think, with this panel. So every one of us really enjoyed it. Thank you so much.
Thank you.
Thank you so much.
Thank you. Bye. Bye.